Hi, and welcome to Cure's Educated Patient Prostate Cancer Summit. My name is Christy Call, Editorial Director for Cure Magazine, and we're excited to have you all here virtually today. Before we start, the Cure patient-focused sessions would like to thank our sponsors, Sun Pharma and Clovis Oncology, as well as our advocacy partners, the Prostate Cancer Foundation, the National Alliance of State Prostate Cancer Coalition, Fans for the Cure, and Cancer Support Community. I'd also like to thank our Summit Chair, Dr. Alan Bryce, for helping us to plan today's meeting. Just as a reminder, be sure to stay until the very end to be eligible for a $200 Visa gift card. Also, don't forget to visit our exhibit hall featuring prostate cancer advocacy and pharmaceutical booths. Today, we will review clinical data to understand what it means for patients, caregivers, and advocates. We'll examine treatment options, offer information about long-term side effects, and look to the future of prostate cancer treatment and what is on the horizon for patients with prostate cancer. First, we will kick off the day reviewing treatment for prostate cancer. It's my pleasure to introduce Dr. Samir Keol, radiation oncologist at Mayo Clinic, who will be discussing radiation.
Thank you. Thank you. Thank you for the kind introduction. I hope people are settling into their virtual seats. We'll just jump right in. Next slide, please. So first off, what is a radiation oncologist? Because we frequently get confused with other providers. So a radiation oncologist has an MD or a DO degree, 5 years of graduate medical education, GME, which is the training part. We are not a fellowship after diagnostic radiology. We used to be about 50 years ago. We do not prescribe chemotherapy. We do, however, prescribe radiopharmaceuticals. And there's about 190 of us that graduate each year, and there's about 3,500 to 4,000 of us in the United States. So that's who we are. I am in that community. Next slide, please. So prostate cancer treatment options, and this is, if you're going to take home, in my opinion, one paper from all this, at least from my talk, this is kind of the Da Vinci or the Mona Lisa of clinical trials. This was called the PROTECT trial, P-R-O-T-E-C-T. It was the trial that people said could not be done. This was done in England. And on the left side of your screen, you'll see the Kaplan-Meier curves that represent relative survival relative to prostate cancer and freedom from disease progression. So this trial was very unique. There was 3 options. And the patients did not choose. This was called a randomized controlled trial. Patients enrolled, and a computer flipped a virtual 3-sided coin, and the patients then received surgery, radiotherapy, or went on what we call active surveillance or active monitoring, coming off for either trigger points or for patient preference. So as you see, prostate cancer specific survival, in other words, being alive relative to prostate cancer, was completely unaffected by the surgery, radiotherapy, or active monitoring. So I always counsel patients that when they're making a prostate cancer decision option, usually it's not so they're alive, but rather they're alive relative to freedom of disease progression, which you see below. In the graph below, you'll see that there's excellent disease control with either surgery or radiation. In fact, they're completely equal to one another. But the patients who went on surveillance had a 10% lower chance of having disease control. And remember, that's with some people coming off for treatment. So when people ask, what are the risks of active surveillance? This is a good graph. On the right side of the screen tells you this is the quality of life relative to the different treatment options, whether it be surgery, or radiotherapy. And remember, they're benchmarked to patients who went and stayed on active surveillance, so who had nothing. They had prostate cancer but didn't receive an intervention. And as a result, you'll see that different treatments have different side effects. And this isn't to say one treatment's better than the other, but they're different and they have different side effects. And that's how I counsel patients to make decisions. Next slide, please. There's three major categories of radiotherapy: external beam radiotherapy, which is radiation from the outside coming in, brachytherapy, which is radiation from the inside going out, and in a branch called radioisotopes, which is an injectable with specific delivery. Next slide. So next slide, please. Oh, and then one more. Okay, so first you see the different, that's a linear accelerator on the left side. There's a representation of the brachytherapy procedure with actual, it's a minimally invasive procedure, and then finally an injectable last. Next slide. So the general process of this is the supply chain. First we see patients, and then we make a decision. This treatment makes sense. Then we would do a CT simulation, if you can hit the advance. And that's what, we would actually do this in an actual CT scanner. We didn't do the treatment planning. Next advance, please. And we actually plan this essentially in a computer-assisted design workstation. And then finally, we do quality assurance. We see patients weekly on treatment, and then we would do a follow-up afterwards. Next slide. We place what's called a hydrogel spacer now. This has, I think, become relatively standard since it's now paid for by the government and most commercial payers. We started doing this several years ago when this was not reimbursed. It costs about $3,300, so that's why it took a little while to get to market. But this is nice because it puts actual like a gel between, and it's dissolvable between the prostate and the rectum. And we do that first along with markers in the prostate. Then we get into that CT simulation that I showed you on the last slide, followed by the MRI and then the treatment planning. Next slide. And this is how it looks. On the left, you'll see a CT, and the visualization of the prostate is okay on that. But in the middle, you'll see a fusion of the two, and on the right side, you'll see an MRI. This is one of my patients. And this is why MRI is so important, in my opinion, in the radiation treatment process, because you can really see the prostate very well. In fact, you can see the sharp contrast versus muscles and soft tissues. And then you can see the spacer in this particular patient very well. Next slide. And this kind of shows on a lateral view how it looks. Next slide. And so there was a trial behind this, and that's why we use this. Next slide. And in this, if you can hit the advanced slide, I want you to focus. There's a lot of numbers here, but I'll walk you through what this means. The RV70 is rectal V70. That's the percentage of the rectum receiving 70 gray, G-R-A-Y, that's our currency, when a plan is going to 80 gray. And you can see the spacer reduces that rectal V70 dose from 12% down to 3%, which is a big reduction, 73% relative. And next slide. And the rectal V70 is an inflection point on what we call the DVH. It predicts for rectal toxicity. Next slide. And here, next slide, you'll see that it decreases the complication rate from 7% to 2%, or the significant toxicity rate. And this was statistically significant. Next slide. And based on this pivotal trial, this is what where the rectal, the spacer became standard of care in men with low and intermediate risk prostate cancer. It's not indicated for men with high risk. Next slide. And you can see how it decreases the dose from 12% down to 3%. Protons, interestingly, which we have without a spacer, is 5%, but when you do protons with a spacer, you lower it down to 1%. So roughly speaking, I would say IMRT with a spacer is equivalent to protons without a spacer. Next slide. And there's multiple radiation machines on the market today. This is an indicator. These are all roughly the same machine with the same type of linear accelerator. Next slide. And what is an X-ray? And what is X-ray therapy? Well, for those of you who had a chest X-ray, the X-ray tube fires and it goes in your back and out your front. This is why we call it a PA X-ray. The P is for the entry point posterior, the A is for the exit point anterior, and next slide, you'll see how it looks that's how a chest x-ray looks. So the difference between an x-ray for diagnostic and an x-ray for therapy is that this would all be kind of a blurred color for a therapy energy x-ray. The x-ray for diagnostic is just a little bit lower energy, allowing a delineation between the different contrasts. Next slide. And actually, in the interest of time, I'm going to skip this. Next slide. Next slide. So proton therapy has what's called a Bragg peak. You can impart a certain amount of energy on a hydrogen ion. That's what a proton is. It's a hydrogen ion. And it'll go a set distance in tissue and it'll stop. It's like kind of like a depth charge. Next slide. And as a result, and based on, we can apply different energies, and you'll see that on the, represented by these 10 different curves, and based on those at different energies and anything in between, we can go anywhere between 0 centimeters deep up to 32 centimeters deep with tremendous precision. Next slide. Actually, in the interest slide, let's skip this. Next slide. So if you remember one thing from all this, it's that protons stop. And this is a very valuable physical property of protons. Next slide. And protons actually do work as promised. Next slide. This is actually a 13-year-old female girl who I treated 12 years ago for what's called a germinoma. We had to treat the spine. So what you can see is the protons go in a set depth and they stop on the planning study, which is on your left. On the middle of your screen, you'll see some white changes. That's actually fatty signal change from the radiation. Next slide. But what you'll see is these fatty signal changes match up exactly where we said the radiation would stop. And that's the power of protons. They actually can stop. They don't. So in this particular patient, the heart dose was decreased by 99%, the ovarian dose by 99%, and everything in between. Next slide. Next slide. And next slide. So, and this is a study published by myself and Carlos Vargas. Both of us were working at University of Florida at the time. Now we're here at Mayo Clinic. This was a big paper at the time. It's 12 years ago. It just showed the dose between the IMRT plans and the proton plans. And essentially, it just shows what, and this still holds true for today, we decreased the rectal dose by about 59% on average when we use protons versus IMRT. Next slide. And this is some of our initial data from University of Florida. Next slide. And next slide. And what focus on the left side, for the freedom from recurrence, at 5 years, low risk prostate cancer had 99% control, intermediate risk had 99% control, and high risk had 76% control. To my knowledge, this remains the best published prospective data in external beam radiation. Next slide. And these are quality of life endpoints. This looks like a busy slide, but really the take-home point is we gave questionnaires to patients at baseline and at periodic intervals after treatment. And so this is baseline versus 5 years after the radiation treatment finished. And if you look, the numbers are remarkably similar for urinary and bowel. These patients had essentially the same quality of life 5 years post-treatment as they did prior to entering radiotherapy. The sexual function is interesting. The higher number is better. Without androgen deprivation or hormones, the baseline was 69, it dropped to 37. With hormones, they were take a pretty big hit early on. So they were 22, they had risen to 32 at 5 years. So a component of that may be radiation, but probably a bigger, just as big a component, or maybe bigger, is the fact that these patients were 5 years older when they were answering the questions. Next slide. And dose escalation, really the take-home point from this is more dose and radiation is better in terms of controlling disease. And up and down, you'll see that the 5-year control rate goes up in 6 different trials. So this is recommended to give more dose when possible. But if you look on the rectal GI toxicity, which is your last two columns on the right, you'll see that when you go from low dose to high dose, you'll get a higher toxicity rate, except for the one study that used protons. Next slide, please. And here you'll see that the low dose toxicity rate was 1%, the high dose toxicity rate was 1%. And so this allowed dose escalation without an apparent increase in toxicity. Next slide. So really, radiation therapy is proton beam is an option. It may or may not be better than IMRT, but there's a trial going on to test this. For many patients, active surveillance is an option. I recognize we didn't get into this for interest of time. And brachytherapy is certainly a very good option for certain patients. It leads to better control for certain subsets potentially, but it also comes with more urinary toxicity. Next slide. I wanted to get in quickly into prostate-specific membrane antigen, because I think this is something that's coming on in the field that hopefully that you may have heard of. It's really originating from Europe, especially Germany, and it's not FDA approved yet in this country. But there's many trials going on. This is a membrane expressed in all prostate tissue, a membrane protein. It's overexpressed in prostate cancer and then further overexpressed in aggressive prostate cancer. It's inversely related to androgen deprivation, so it gives us a nice tool so it's inversely proportional to how PSA would act. It's a three-part structure, and we're able to label things to the external portion of it. Next slide. It can be used diagnostically or therapeutically. And in diagnostic, it's latched up to something called gallium, which is a positron emitter, and we can put patients in a PET scan and we can actually see activity. And this is a study from the Mayo Clinic group comparing the different agents, and it appears that choline 11, which was actually, in full disclosure, invented at Mayo Clinic and is patented, used to be the heavyweight champion. It looks like PSMA is going to be just a bit better. Both of these will be better than fluciclovine, which is the most commonly available FDA-approved agent in this country. Next slide. Therapeutically, you can use that PSMA extracellular membrane component and latch it on to different isotopes. The most common is lutetium. This is what's called a beta emitter with gamma decay. So this is attractive to us because the beta emission makes sure that there's limited range, so it doesn't go far beyond the target, and then the gamma decay allows us to image it. It has a relatively short half-life, and then it seems to have excellent PSA response in early trials. There's an ongoing phase 3 study that will really give us some definitive answers. Next slide. But at the most recent ASCO meeting, which is the largest oncology meeting in the world, there was something called the Therapy study, which was presented. And this was the first randomized trial comparing the lutetium PSMA complex radioligand to a relevant control arm called cabazitaxel. That would be Dr. Bryce's specialty in men with hormone-resistant prostate cancer. And the take-home point is that if you go down to the fourth bullet, the PSA decline was significantly more in lutetium than it was for cabazitaxel. And if you go down to the last 2 points of toxicity, basically there was far less toxicity in patients who received, I'm sorry, I have those numbers backwards. I apologize for that. It was 8% lutetium and 40% cabazitaxel. So there was far less toxicity with lutetium. I apologize for that. Next slide. So conclusions, active surveillance is appropriate for many patients. I couldn't get into this due to time, but happy to take questions in the Q&A, as I'm sure Dr. Tyson is. Radiation is an option for most men with prostate cancer that is localized to the prostate. For certain men, radiation is better than surgery. For certain men, surgery is better than radiation. And for a lot of men, it's really 6 of one and half dozen of the other. And then obviously there's external beam versus radiotherapy. And then lastly, if the cancer is spread, then certain radiopharmaceuticals may be appropriate. Again, radium, which I did not get into, is FDA approved. We do quite a bit of that at Mayo Clinic. lutetium PSMA is not FDA approved at this time in this country. Thank you.
Great, thank you so much, Dr. Keough. So next we have Dr. Mark Tyson, Associate Professor of Urology at Mayo Clinic, who will talk to you about surgery.
Good morning, thank you, Christy. My name is Mark Tyson. I'm a urologist here at Mayo Clinic in Arizona. Specialize in cancers, urologic cancers. Delighted to be here with you this morning. I hope that this conference is helpful for you in learning a little bit more about options and what might be on the horizon for prostate cancer treatments. Next slide. I'm going to review the basics of surgery. We'll talk a little bit about the goals of surgery as well, the side effects, both common and uncommon effects of surgery. And we'll also spend a little bit of time talking about emerging treatments in the focal therapy space. By way of disclosure, I don't have any disclosures relevant to this talk. Next slide. So the vast majority of radical prostatectomies done in this country are done robotically. Historically, we used to make a lower midline incision. It's a big incision to take out the prostate, but over the last couple of decades, we've seen the robotic technology really take over in this space. As you can see there to the right is what the operating room looks like when we do robotic surgery. To the far left in that picture, you can see the surgeon sitting down in her console there, and then you can see numerous nurses at the bedside, as well as surgical assistants at the bedside, putting instruments in and out in that big white robotic arm, the forearms draped over the patient there. You can't even see the patient. In terms of outcomes, typically patients would spend one night in the hospital after this operation. We're now to the point where we're doing about half to 3/4 of patients going home the same day. You do still have a catheter in your bladder for 7 days, whether it's done open or robotic. And I do like to make the point with patients and talks like these, open is just fine. You have a surgeon who says, I've done thousands of open prostatectomies, and we either don't have the robotic technology here where we live, or I don't want to adopt it. That's okay. Aside from a little bit of, maybe a little bit more pain, maybe another day or two in the hospital, there's really no difference. Long-term outcomes like urinary incontinence and erectile dysfunction and cancer control are about the same, whether it's done robotic or open. Next slide. When we do these robotically, this is what your incisions can look like, what you can expect them to look like once you've healed. You've got little tiny 8mm robotic ports, 4 of them across the abdomen, a 5mm assistant port, a 12mm assistant port. And you can see the incision just below the belly button there. That one was extended to extract the prostate. Next slide. Post-op complications after this are pretty rare in terms of perioperative complications. You do have some incisional pain, obviously, even when it's done robotically. Nausea is pretty common due to the effects of anesthesia. Sometimes patients will complain of urinary tract burning with the catheter in. Almost everybody complains of constipation, to the point where we just put everybody on a bowel regimen. Wound infections are pretty rare, but urinary tract infections are not uncommon. Patients with the catheter in for 7 days, and when you excise the prostate, you obviously enter the urinary tract, and so infections are not totally out of the ordinary. You can develop scar tissues, and occasionally patients, they'll develop urine leaks and require catheters in for longer than 7 days, but not usually more than an extra week or two. Those are pretty rare complications. Every now and then there's damage to another structure in the area, like the rectum or a major pelvic vessel of the bladder. And occasionally, early in the robotic experience, decades ago, we would see patients with lower extremity injuries from positioning. These are all really, really rare complications, but they're important to remember that with surgery, we take nothing for granted. Next slide. Perhaps the most rare of complications that we see sometimes after surgery is lower extremity edema after a lymph node dissection. Really, it's far less than 1%. But if you are going to have surgery with a pelvic lymph node dissection, it's important to realize that this is a possibility. Occasionally, as you can see on the bottom of the slide there, we occasionally have to involve the plastic surgeons to restore the microcirculation of lymphatic flow back from the legs to the heart. Next slide. There are certain types of patients who, in general, are not good surgical candidates. In general, if somebody shows up kind of in a wheelchair on oxygen, that's a good sign that they're probably not healthy enough for surgery. We're also looking to make sure patients are going to live long enough to benefit from surgery. As Dr. Keel showed you, the 10-year survival of patients is really good in the PROTECT study. And so we're really looking for patients who have a horizon of 10, 15, 20, 25 years. If we know somebody's going to die of a heart attack 5 years later, which none of us have a crystal ball, but if that's more likely than death from prostate cancer, then we tend not to operate on these patients. Another class of patients that we tend not to operate on are patients with metastatic disease. If somebody has widespread disease that's spread from the prostate to the liver and the lungs and the bones, then we tend not to operate on those patients as well. They need systemic therapy, and Dr. Bryce and Dr. Moore are going to talk more about that later. There is a subset of patients with limited metastatic disease that we may consider operating on or doing radiation therapy in, but this is a little controversial and currently under study at the moment through the Southwest Oncology Group. In general, though, if a patient has metastatic disease and they're a candidate for local therapy, either with surgery or radiation, I tend to favor radiation in that setting to minimize the impact on the immediate impact on their quality of life. Next slide. I do want to spend a minute talking about active surveillance. Not all cancers need to be treated. Dr. Keel showed you this graph earlier from the PROTECT study, and I want to reiterate that I think it is one of the most important things that as a patient you could look at in helping make your treatment decision. In patients who have Gleason 6 disease and selected patients with low volume Gleason 7 disease, there is no question that active surveillance is the best initial strategy. And what's that based upon? If you look at the top part A of this graph, you can see surgery in the red line there, radiotherapy in the blue line, active monitoring in the green line, and you can see the percent of patients surviving on the y-axis over time on the x-axis at 10 years. And the reason why we often recommend active surveillance for patients with low and very low risk disease is because we cannot look you in the eye and tell you that treatment is going to materially alter your survival outcome over a 10-year period. As you can see in that graph, the predicted probability of death is precisely the same whether you choose surgery, radiation, or active surveillance. And this is a very important concept. And a lot of patients will say, well, doc, you just said that 10 years isn't necessarily the goal, it's 15 or 20. And that is true. We don't have 15 or 20-year data comparing all three, but we will eventually. And that's why I said that this is often the best initial strategy, because as Dr. Keel pointed out on the lower panel there, panel B, we do know that some patients on active surveillance, about 30% at 5 years, will develop either a progression in their PSA, a progression in their Gleason score, a change in their MRI, or a change in some other aspect of their health or disease that necessitates treatment. But it doesn't necessarily mean that we can't get a little bit more mileage out of their function in the meantime. Next slide. So let's talk a little bit about the goals of surgery. One of the most common things that I get asked the first time I see a patient after surgery is, doc, did you get it all? It's a great question because it demonstrates that the patient is appropriately focused on the number one goal of treatment, which is to cure the cancer. And what I want to reiterate is that the risk of failure is directly related to the risk of disease. The more risky the disease, the more likely one is going to need additional therapy after surgery, like hormone therapy or radiation. If a cancer is clinically localized to the prostate and you have negative margins and you get the whole thing out and reconnect the bladder back down to the penis, then the job is done. The cancer is cured and the patient will live the rest of their life without a problem. But that's not always the case. Next slide. Here's a couple of routine scenarios. And this comes from the CAPR-S scores out of UCSF. And it's a very helpful nomogram for patients as they determine after treatment, or sometimes before treatment,
what their risk of failure is, and whether or not they need additional therapy. So let's take the first scenario, very common scenario, a patient with higher volume Gleason 3+4 disease. They undergo surgery. We get it all, quote unquote, with negative margins. There's no evidence of the cancer having penetrated the capsule or into the seminal vesicle. It has not spread to the lymph nodes. LN stands for lymph nodes, and their PSA is reasonable. It's 6. They have an 83% chance of being completely free of disease at 5 years, having an undetectable PSA. This is a very good outcome, and this is the one where we tend to think, most of these patients are going to survive the cancer. But as you can see, as risk increases, the risk of failure also increases. So in the second patient there, Gleason 4+3, we get it all, quote unquote, because the margins are negative. But the pathologist tells us, you know what, doc, there's a little bit of cancer spreading outside the capsule into the fat. The PSA is 9. That's somebody that I would give a 70% chance of having an undetectable PSA at 5 years. If you up the Gleason score a little bit and go to Gleason score of 8, you get it all with negative margins. There's no evidence of the cancer spreading into the fat or the seminal vesicle or lymph nodes, and the PSA is 12. That would still give you a less than 50% chance of success at 5 years. And if you have Gleason 10 disease with positive margins, extracapsular extension, seminal vesicle involvement, lymph node positivity, and a PSA of 21, that patient has almost a 0% chance of having an undetectable PSA at 5 years after surgery. And so these are patients that we would tend to say you need additional therapy. Next slide, please. Well, what is additional therapy? Well, in the case of positive lymph nodes, we tend to recommend hormone therapy for 2 years. Hormone therapy has been shown in that setting to improve survival in a large cooperative group study published through SWOG. If we give you 2 years of hormone therapy, you will have a better survival outcome than not. In the instance where the cancer is not in the lymph nodes, but the cancer is spreading into the fat around the prostate or into the seminal vesicles, these are patients that we tend to pick up the phone and call Dr. Keogh and say, Dr. Keogh, would you be willing to give this patient radiation therapy as an adjuvant measure, as a prophylactic measure, as an insurance policy, if you will, against the cancer coming back? This is especially true for patients who have positive margins and are young. In certain patients that are older with negative margins, if they have extracapsular extension, we might not necessarily rush into doing radiation therapy, but follow their PSAs over time. Next slide. I do want to make a quick note on hormone therapy. Hormone therapy, for the most part, men tolerate that reasonably well for the first year. They do notice some fatigue and loss of libido, erectile dysfunction, bone mineral loss, breast enlargement, loss of muscle mass, etc. All of those things are true, but really that type of experience builds over time. And I think Dr. Moore and Dr. Bryce can attest, and we'll probably discuss that it's really the long-term side effects of hormone therapy that give us concern. A year or two of hormone therapy is generally well tolerated by patients. And it is reversible if it's not tolerated. Once we complete the regimen, once we stop doing the injections, those side effects, many of them, will reverse. They're obviously not reversible for patients who have orchiectomies. That's the removal of the testicles. Next slide. So if the primary goal of surgery is to cure the cancer, the second goal of surgery is to preserve function. And the first function that we're really looking to preserve is urinary incontinence. It's pretty common for patients to complain of leakage after surgery, especially within that first 3 to 6 months. But it's pretty uncommon for patients to complain of really, truly bothersome urinary leakage at a year. I tell most of my patients that in that first 3 months, you're going to really be doing a lot of Kegel exercises. You're going to transition from 2 to 3 pads a day, hopefully down to 1 pad a day. But it's not necessarily something that's going to get better in the first 3 months. It usually takes 3 to 6. And as a side note, I have a lot of patients who come in and say, well, my other doctor told me that they've never had any patient that's been permanently incontinent after this operation. I would consider that to be a disqualifying statement. If a doctor says that to you, I think that they have disqualified themselves as being a good doctor for you, because that's simply not true. We know that there is a risk of incontinence, and we do the surgery the same way every time, and yet some patients have a miserable experience after surgery, and other patients do just fine. Nerve sparing usually helps, by the way. So if you're able to have a nerve sparing operation for erections, which we're going to talk about in a second, that can also help with preserving the pelvic floor musculature and tone. In patients who are permanently incontinent after this operation, we tend to recommend a referral to somebody like Dr. Walter, who's going to talk a little bit later, to consider a permanent solution to their problem, such as a sling or a sphincter. And these are surgical procedures that can make a patient dry again. Next slide. In that sort of second goal of surgery, preservation of function is the secondary goal, goal number 3, of preserving erectile function. This is much more common. Erectile dysfunction is much more common after surgery than urinary incontinence. Even with nerve sparing, patients will usually complain of some degree of erection loss or some degree of loss of their sexual experience. Now, a lot of men obviously are notorious for not being truthful in this regard and say, no, everything's just fine. But if you get down to brass tacks, most people would say, yeah, my erections are okay, even with nerve sparing on Viagra, but they're not quite the same. And obviously, you lose the ejaculatory function because those organs are removed during surgery. We usually start by treating this disease with oral medications. You can also consider mechanical pumps, injectable medications, and in the worst case scenario, next slide, you could consider a surgical prosthetic. And Dr. Walter is going to talk more about this a little bit later. This is a very uncommon need after this operation. Most people will have good function with Viagra or the injectable medications or the penile pump. You usually don't need this surgical procedure, but some people do, and it works very well. Next slide. I'd like to spend a couple of minutes talking about where I think the surgical field is headed. A lot of patients will say to me, but doc, if the cancer is only in one region of the prostate, why are you going to take out the whole prostate? Why would you radiate the whole prostate? And you know what? That is an excellent question. As you can see on the right side here, this is an MRI. You can see where the arrow is pointing to that dark spot in the white horn there. That is a cancer that is localized to one part of the prostate. Is there a way to just treat that one area of the prostate while leaving the rest of the prostate alone, with the obvious benefit being you'd preserve function to a much greater degree than you would with surgery or any other therapy for that matter, and you would avoid the obvious downside of active surveillance, which is what if the cancer spreads while on surveillance? So this tends to be a good option for at least a consideration for many patients with newly diagnosed prostate cancer. Next slide. This is what we're doing in Mayo Clinic in Arizona at the moment. We're doing high intensity frequency ultrasound with this machine called Focal One. It was FDA approved for prostate tissue ablation, not necessarily prostate cancer ablation, but prostate tissue ablation last year. We've been doing it for about a year. A patient comes in, lays on the side, goes to sleep. It requires general anesthesia. We put an ultrasound probe into the rectum, and we sit at this computer. It's a computer-assisted, MRI-assisted focal ablation of the prostate. So we use heat, ultrasound waves, sound waves, to generate heat to ablate just one region of the prostate. Next slide. The clear advantages of these are that it's same-day surgery. You walk in and walk out feeling roughly the same. Even with robotic prostatectomy, when you go home the same day, you're still having some pain and you have incisions and those kinds of things. With this, you don't really have that. You don't have pain. You don't have incisions. We're only treating the region of interest. So we're not treating the whole prostate gland. Whole gland is possible. Whole gland treatment, whole gland ablation is possible. But in patients who recommend or who request that, I say to them and I say to myself, why not just do proton beam therapy? If you're going to treat the whole prostate and you want to avoid the side effects of a radical prostatectomy, I think you're better you're better off with proton beam than you would be with whole gland HIFU or cryotherapy. And admittedly, that's a controversial topic, and that's just my personal opinion. I tend to steer those patients towards radiation as opposed to whole gland therapy. You still have a catheter for 3 days, and in our initial experience over the last year, the side effects are minimal. Patients urinate with the same function or dysfunction that they urinated prior to HIFU. They have erectile function to the same degree that they had before and after HIFU. The obvious disadvantages are that it requires general anesthesia, and it's not well studied. I can't look patients in the eye like I can with that other study that we showed you, the randomized trial from England, the PROTECT study, and say what your predicted probability of death is after the surgery or your predicted probability of recurrence. We're not treating the whole prostate gland. So your risk of recurrence is higher by virtue, if for no other reason, by virtue of not treating the rest of the prostate. Your other parts of your prostate could produce additional carcinomas, and prostate cancer is well known to be well known to occur in multiple regions of the prostate, something we call multifocal. And the last downside is contract insurers don't yet cover it, and it's cash pay for patients who are not yet in the Medicare age group. Next slide. As I mentioned, it's important to remember that it's not as well studied, but there are some ideal candidates for this, and I think that this is really going to expand over the next decade. Patients with Gleason 7 disease isolated to one region of the prostate that's not in the apical region of the prostate, because the heat gets a little too close to the sphincter. And with good baseline function, these are patients that tend to be really good candidates for this. Patients who are not good candidates are patients who have high-risk disease. We don't offer this to patients with Gleason 8 disease. Patients with disease that's near the sphincter, the apical disease, or with thick rectal walls, history of colitis or prostatic calcifications, because that can impair the effectiveness of generating heat through the HIFU. Next slide, please. So in summary, surgery is a multifaceted discipline. It can be done open. It can be done robotic in terms of a radical prostatectomy. Recovery might be a little faster with the robot, but otherwise outcomes are about the same between open radical prostatectomy and robotic radical prostatectomies. Incontinence, at least temporarily, is very common. Permanent incontinence is rare. Erectile dysfunction is very common, even over the long term and even with nerve sparing. Most patients with clinically localized disease are cured with surgery, but there are some high-risk patients that need additional hormone therapy or radiation therapy to clean up some additional disease that's either local or metastatic. And I think emerging surgical technologies like HIFU and cryo in a focal fashion will likely dominate the surgical landscape decades from now. But at the present time, it's a new surgical approach, and it should be reserved for highly selected and well-informed patients. Thank you for having me. I appreciate your time and attention.
Thank you so much, Dr. Tyson. I'd like to welcome Dr. Keel back for our panel discussion, and also joining Drs. Keel and Tyson, it is my pleasure to also introduce Ed Randall from Fans for the Cure. To start, I'd like to open the panel for audience Q&A. So if you do have a question, please just be sure to type it into the box on the right-hand side of the video presentation. So we have a couple of questions that have already come through the chat. So Dr. Keel, who do you recommend goes on active surveillance?
Oh, well, thank you for the question. I'm sure Dr. Tyson will have some feelings as well. I heard this from one of my mentors decades ago, and it really rings true today with more follow-up data. I think for men with low risk, 15-year life expectancy, low risk prostate cancer, 15-year life expectancy should be the standard. For intermediate, it might drop down to 10, and for high risk, one would argue 5 years, or anybody who really comes in the door with high risk should be treated. But in terms of parameters for surveillance, Gleason score 6 and certainly low volume Gleason score 7, that's a primary component of a 3, PSA under 10, and without any aggressiveness that's detectable on the digital rectal exam. Sometimes we send these patients off for some genetic profiling, but I don't do that routinely. So that's who I use as those are some of the basic parameters I use for patients I recommend surveillance to.
Okay. And Dr. Tyson, did you have anything to add to that?
I think that's well summarized. Patients with Gleason 6 disease, for the most part, are almost always going to be good candidates for active surveillance initially. Almost never say never, but almost never would we operate, or would I operate on a patient with Gleason 6 disease. It would have to be a pretty special case, really high volume Gleason 6 disease in a young person. That might be something you could consider, but for the vast majority of Gleason 6 patients, those are going to be surveillance patients, patients with PSAs under 10, and then patients with Gleason 3+4. So as Dr. Keel mentioned, they have secondary pattern 4, Gleason 7 disease, but their pattern 4 is relatively low volume. It's isolated to one region of the prostate, and it's not occupying a significant percentage of the cores. We do tend to use that, what Dr. Keel just mentioned, the genomic profiles for patients who are in that favorable intermediate risk category clinically, because then those probabilities that the genetics spit out, because what they'll do is they'll take your tissue and they'll look at the expression of certain genes, and they'll spit out percentages to say, well, what is the likelihood of you having sort of death from disease 10 years from now? And we can share that with the patient and say, okay, now how do you feel about these percentages? And if they feel good about being in that sort of favorable intermediate risk setting, then we can say, okay, active surveillance is your option. If they don't feel comfortable with it, then we can say the genomic profile helped us. You have an intermediate risk disease that's a little higher risk, and so we should proceed with therapy. So I think that's how I summarize it often for patients.
Okay, and so another patient asks, when can we expect PSMA scans to be approved by the FDA?
As soon as they approve it. We are also waiting. I don't know if Dr. Tyson knows anything more than me. We're following it. We're very, very excited. We think it's going to be useful for both diagnosis and the therapeutic aspect on the lutetium, but I just don't have any idea on when we'd expect. I think it would be in the next few years, but is it going to be in 2021? I don't know.
I agree. I don't know either.
Okay, and so we talked about two different treatment options. Ed, I just want to jump over to you for a second. As an advocate, why do you think it's important for patients to know about their treatment options and to, kind of advocate for themselves when it comes to deciding their treatment with their doctor?
Well, I can certainly talk about my own experience and what an honor it is to be with all of you this morning and this afternoon. And to compliment the doctors on their wonderful presentations. I was 47 years old when I was diagnosed, which was relatively young, and my treatment options were left to me. I was very fortunate that there was no pressure put on me with regard to which way I wanted to go. My PSA was 17, but my Gleason was only a 4. So that left some options there, and I was treated at St. Luke's Roosevelt Hospital here in New York. Now it's part of the Mount Sinai system, and I was in the capable hands of the chairman of the urology department there, Dr. Nicholas Romas, and he put no pressure on me. It was really, at that time, a question of, did I want to have the radical prostatectomy, or did I want to have this relatively new procedure, the implantation of radioactive seeds, and I chose the latter, and fortunately it was inserted and ate the cancer. But I think it's very important to not only talk to patients about what options they have, but also to tell them on the back end what effects they may have from whatever choice they have made. At Fans for the Cure, we conduct a men's health support group every second Thursday night, and we're getting people from all over the country that join us. And one of the universal themes has been the opportunity for them to share their post-op experiences and talk about, I didn't know that this was going to happen. And there's a lot of distress in their voice about that, but there is also this collegiality of others that also join us and go, you know what, Bob, that happened to me and nobody said anything to me. So I think it's really important for the doctors to talk about the fact that on the back end, there could be some effects to your quality of life, but to lay it out as best as they possibly can.
Okay, great. So we have another question. Does nerve-sparing approach to RP make any difference for ED and incontinence, or has Dr. Walsh's theory been oversold?
No, I think it does, and I think you can quantify it. Marty Sanda's work, as well as Dave Penson, they both, and Mark Litwin, they've all published good data in this regard. Nerve sparing does seem to offer some benefits. If you look at sort of in an EPIC survey, where you have, it's 0 to 100, and 100 is perfect function and 0 is pretty bad, it's 10 to 15 points better, right? So on average, there is definitely an effect of nerve sparing, but the question is, you have to temper your enthusiasm for that effect. And that's what I meant to say, is that, when patients come in, I really reiterate that, with nerve sparing, things can be pretty good, but they're probably not going to be where they were. And that's an important consideration. And like I said, there might be other benefits of nerve sparing too, in terms of urinary function. So in patients that are candidates for nerve sparing, we tend to offer that. But remember, with the rise of active surveillance, we're doing more and more active surveillance in these patients, which is the ultimate nerve sparing, if you think about it, right? Not treating the prostate and preserving function for as long as we can. And in patients who are going to surgery, we tend to operate nowadays on patients with more advanced disease, more aggressive disease. And so we're not doing nerve sparing in patients, with Gleason 9 clinical, T3 stage prostate cancers, because remember, the number one goal of surgery is to cure the cancer, and the nerves go right through the prostate. Nerve preservation could leave cancer behind. So it's a delicate balance between curing the cancer, preserving function, when you consider nerve sparing.
Okay. And we have another question. Is it true that radiation provides greater preservation of urinary and sexual function?
I think so. I think that data would be supported in two pivotal papers in our literature, and one is from the data that Dr. Tyson just mentioned, which is Marty Sanda's paper that was in New England Journal of Medicine in 2008, and that's open access. And then the PROTECT trial, we didn't get into the details on the quality of life. There was two articles in that. One was on the outcomes in terms of control, and the second article in there was written by a woman named Dr. Donovan, who talked about quality of life. And so there did appear to be, and it was statistically superior preservation in terms of urinary and erectile function. But the big component, again, is age, especially on the sexual function component. So, and obviously there's a lot of factors in there, as Dr. Tyson alluded to, especially the issue of a dual sparing nerve prostatectomy, because that took all comers. And so if you only, and he'll speak to this better than me, but my understanding is if you don't do any nerve sparing, there's going to be no preservation, but even one nerve bundle is a pretty big hit. But there's not great data I'm aware of with dual nerve sparing prostatectomy versus radiation, because some of that data is biased in that it's all comers of prostatectomy.
Okay. And
I could maybe, I could maybe chime in. Am I able to share my screen? Oh, I can't share my screen. While another participant is sharing. There is, I wish I could share my screen. I wish I would have included these in there. In short, I think that Dr. Keel is right. I think in the short term, preservation of urinary and sexual function is going to be better with radiation than it would be with surgery. There's no doubt that when one has a radical prostatectomy, for the first 3 to 6 months, it's learning how to regain control of the urine and learning how to get your erections back. Most patients don't have to do that have radiation. But there are two important considerations, and I wish I could show the graphs that I show patients in the clinic. Paper published that my mentors published together a couple years ago in JAMA, really good longitudinal cohort series of patients undergoing radiation, surgery, and active surveillance, and what their EPIC function scores are, so what their disease-specific urinary sexual health is over time. And what you see is that you see a pretty large and significant decrement in function after surgery initially, but recovery back close to baseline levels. And you see a little bit of that with radiation too. But over the long term, you have precisely equal rates of erectile dysfunction and urinary incontinence, irritative voiding symptoms, and hormone domain scores between surgery and radiation. It's just a pattern of side effects that's more acceptable to you. And the other thing that, you'd say, well, why wouldn't everybody just do radiation if there's no there's no initial downside to the urinary function and sexual function? But as Dr. Keel could probably talk about to a greater detail than me, is that you still have late toxicity of radiation therapy that you don't have with surgery. And so strictures of the urethra, bladder neck contractures, those kinds of things, secondary malignancies of the bladder and the rectum, radiation cystitis, radiation proctitis, insufficiency, fractures of the pelvis, sarcomas, etc. There's a lot of things that you get with radiation therapy that you wouldn't get with surgery. And so, yes, it's true. For preservation of urinary and sexual function, I think over the short term is better. Long term, I think those rates equalize, as we've seen from the Caesar data and Marty Sanders' work that Dr. Keel just mentioned. But there's additional risks with both that have to be considered on balance.
Okay. And another patient has asked, what is your view about debulking for patients with metastatic disease?
We don't know.
Yeah, we don't know. That's currently something that's under study at the Southwest Oncology Group. Patients who have limited metastatic disease, so disease that's in the bone, a few bone sites, maybe a few lymph nodes, and they oftentimes have locally aggressive disease to the point where they're either developing some symptoms like urinary obstruction, urethral obstruction, or bleeding. And those patients, you could consider doing some type of therapy, whether it's radiation or surgery, for something we call local control of disease, to help them urinate again better, or to help them, help their kidneys drain better. Those kinds of things. You could consider doing local therapy for those settings, but they're really rare cases, and they need to be considered sort of on the, sort of individually on a case-by-case basis.
Yeah, to follow on that, I think it's when I was a resident, and that was a long time ago, there was a randomized study published in New England Journal of Medicine. This is patients with metastatic kidney cancer, where that study showed that there was a benefit in terms of survival for men who had the diseased kidney removed, even though they had metastatic disease. And then this study was repeated and then on a wider scale and didn't show that difference. But the difference with prostate cancer versus metastatic kidney cancer is we can keep people alive for a long time with very good quality of life with prostate cancer. We can't do that as well with other diseases. And so that's why I think this is an interesting question. It's a great question, and one nobody I think could say they definitively have the answer to, but this is an interesting question.
Definitely. So this is one that we hear a lot more and more now recently. How important is genomic and genetic testing, especially if you're trying to determine the best candidate for active surveillance?
Yeah, I think, and obviously, just so everyone knows, Mayo Clinic has been heavily involved in the validation of several of these genomic tests, and so this is something that perhaps we're a little bit biased on, not financially, but just I actually, even though Mark and I did not talk, Dr. Tyson and I did not talk about what we were going to talk about beforehand. I use it almost exactly, I think, the way he does. the genomic profiling isn't going to help me in low risk unless it's high volume. But even then, I'm going to probably recommend treatment there, but it might help me there. It's not going to help me in what we call unfavorable intermediate risk, because I'm going to recommend some type of treatment, and same with high risk. It's going to help me in a relatively small number, and it's those favorable intermediate risk that I'm on the fence for active surveillance. That's where I order it 80% of the time, I'd say. There's some, obviously, it's not one size fits all, but almost every time, 4 out of 5 times I'm ordering it, it's for that man, and it's surveillance versus definitive therapy. So it's not a huge percentage of patients in whom I order it.
Yeah, I think that when we talk about genetic testing, we have to distinguish between the genomic testing of the tissue and germline testing that Dr. Bryce will probably talk about a little later. The results of the first biomarker selected clinical trial in the prostate cancer space read out a few weeks ago, and there's a signal in that space with olaparib, and Dr. Bryce can talk to you more about what the germline mutations mean and what germline testing might be beneficial for patients with prostate cancer. But as Dr. Keel said, on the front end, for patients that we're seeing in the clinically localized setting, the Oncotype DXs, the Prolarises, the Deciphers, those are tests that we use to answer very specific questions. If a patient says, I'm really not sure how I want to proceed, that additional information could be helpful in guiding treatment decision-making. On the front end, it could be helpful in deciding between doing surgery and radiation or not doing anything, doing active surveillance. On the back end, it could be used to help decide for patients who want to get additional therapy after surgery, like with radiation, for example. Although I will tell you that unlike some of the other spaces where this is well studied and validated in a randomized controlled fashion, I'm not aware of any sort of high quality experimental data saying that you need to do X, Y, and Z to make a certain decision. We use these because they're validated and they're helpful, but it's not a hard and fast science.
Okay. We have a question. Does mild radiation proctitis usually improve, worsen, or remain the same?
Good question. Usually, mild radiation proctitis doesn't advance on its own. It's different than urinary. Urinary toxicity or injury to the bladder can actually, it's what we call not just a late tissue, it's a very late reacting tissue. You can see cumulative impacts 20, 25, 30 years down the road. Generally speaking, what we get with radiation proctitis is what we get, and we usually have a pretty good idea within 2 to 3 years. That being said, these days with modern radiotherapy techniques and even doesn't need to be protons, even with IMRT, it's pretty rare you get big doses to the rectum enough to cause significant proctitis. This is much different than 10 and certainly 20 years ago.
Okay. And then can you discuss the different options for patients that have had unsuccessful surgery or radiation and are now dealing with cancer that has spread?
Go ahead, Mike. Mark, do you want to?
Yeah, sure. Yeah, we see this frequently. It's obviously the risk of failure is higher as the disease risk increases. So I have a lot of patients who have Gleason 8 disease. We take out the prostate, the margins are negative or positive, and the disease is in the fat around the prostate or in the seminal vesicles. And they recur. When they recur early, so when the PSA comes back in the first 3 to 6 to 12 months, we tend to worry a little bit more about metastatic disease, disease that was already spread at the time of surgery, although that's not always true. And when patients recur late, so they've gone 3, 4, 5 years with an undetectable PSA and their PSA slowly starts to rise, then we tend to think of local recurrences. In both of those situations, though, we do advanced PET imaging scans like C11 or Axumin or hopefully soon PSMA, and we can identify, the extent and the volume and distribution of the disease before making treatment decisions. I'd also note that I have several patients who have recurrent PSAs that don't change over time. They become detectable at 0.11. We recheck it again 3 months later, it's 0.11. We recheck it over the next 3 years, it's 0.11, 0.12, 0.13. And we're not sure what to make of that, although that's a pretty rare scenario. But I would say that there is a high risk of biochemical recurrence or PSA recurrence, and that risk increases as your disease risk increases.
And then we have two of the same question, actually. So after having radiation, is it true that follow-up surgery is a lot less of an option?
I don't think that, I tell patients that that's not true. I think that patients, if they want to do radiation, I fully support them, and I don't let that influence their decision, because for the most part, people don't need salvage prostatectomies after radiation therapy. As you saw from the graph earlier, Dr. Keel showed and I showed, radiation therapy is just as good as surgery at curing disease over a 10-year horizon. So most patients don't need salvage prostatectomy, first of all. Second of all, it's not true. We do salvage prostatectomies in patients that need them frequently at Mayo Clinic. I know that sounds like I'm saying two different things. Most patients don't need it, but yet we're a referral center, so we still see a lot of patients who need salvage prostatectomies, and we still do a good surgery in those patients. I do tell those patients that the risk of erectile dysfunction and incontinence is a little higher after having had radiation, but technically speaking, surgery after radiation, or HIFU for that matter, is technically possible, yes. And that should not be a reason why you choose surgery over radiation.
Yeah, Dr. Tyson is being modest. What I would say is really any board certified urologist should probably be able to do an upfront prostatectomy. That being said, not many do. Many just, they don't touch cancer after their training. So then you've whittled it down to the number of surgeons that do radical prostatectomies on a regular basis. The number of surgeons who do what we call salvage prostatectomies after radiation is incredibly small. This truly, you need to go to a center of excellence where there's high volume. We have one of the top urology departments in the country, so our surgeons do these in relatively high volume. This is not something, if you're considering a salvage prostatectomy, you need to go to a center of excellence for urologic oncology. This is not something you do on the street corner.
Okay, and then there was a question for treatment options for low PSA Gleason 10 localized prostate cancer. If you could discuss maybe some options for those kind of patients.
Okay. Low PSA Gleason score 10 prostate cancer, I'm sure we're all thinking the same thing. Mark and I are thinking the same thing, and so is Dr. Bryce, who's on. This is not producing PSA. This is so what we call de-differentiated. There's a certain percentage of prostate cancers that don't read the book and behave differently, and they should look differently under the microscope, but not always. These are the patients in whom we'll always get the full battery of genetic testing. But my assumption is not that they have a low PSA because they're low burden. It means they're not produced. They're so de-differentiated. They just don't resemble the background prostate tissue. They're not, they don't create PSA. Those patients are very tough to cure.
I would say that this brings up an important point that we haven't discussed. And that's somebody who has this type of disease very likely has at least locally advanced and probably metastatic disease. And not always, it can sometimes be clinically localized, but this is somebody who I would definitely do a prostate MRI in before doing any treatment planning. If there's evidence of the cancer sort of invading into the rectum or invading into the pelvic floor, that's a patient that really is better off with upfront systemic therapy and radiation therapy. Radiation oncologists can treat a wider purview of tissue than surgeons can resect. And so if we think it's true that somebody with this type of prostate cancer, I'd start by getting an MRI, and I'd start by really considering upfront systemic therapy followed by radiation therapy if there's evidence of locally advanced disease. Because to to do surgery to get all that out, you may have to take out the bladder. You may have to take, you may end up doing a lot more when there's a minimally invasive, highly focused, proton beam option.
Well, that is all the time we have left. I'm sorry if we were unable to get to your questions, but thank you to our panel, Drs. Keel and Tyson, as well as Ed. We really appreciate it. We're now going to take a short 10-minute break. Please don't forget to visit the exhibit hall in the Summit lobby, and we'll see you back at 2:20. Thanks.
Great.
Hi, and welcome back. So in our next session, we'll be discussing long-term effects. It's my pleasure to introduce Dr. Cassandra Moore, medical and hematology oncologist at Mayo Clinic. And she'll be discussing health maintenance, including bone health, cardiovascular disease, and diet and exercise.
Hey, sorry, if you could just unmute your microphone.
Sorry about that. Yes, can you hear me? Okay. So as Christy mentioned, I'll be discussing bone health, cardiovascular, diet, and exercise, and thinking about long-term effects of prostate cancer and its treatment. So next slide. So I have no disclosures. Live life healthy. Why is this so important? The foods you choose to eat and the amount of physical activity you get can impact your health as well as your prostate cancer risk, recovery, and survival. Next slide. So recent data does suggest that obesity, which is defined as a body mass index greater than 30, smoking and uncontrolled medical conditions, for example, diabetes, are associated with a more aggressive prostate cancer and worse outcomes. Studies also suggest that a healthy diet and regular exercise not only may lower your risk for prostate cancer, but also help you prepare for and recover from cancer treatment and the cancer itself. And it may also help your cancer from coming back. Diet and exercise may also help deal with treatment effects in several ways. Next slide. So effects of treatment, the big one that most people think about is the effect of hormone therapy. And these treatments for prostate cancer, although they benefit the cancer treatment, can have negative impact on your body. So not only does normal aging process, but also hormone therapy can lead to loss of muscle mass and bone density, which can possibly result in osteoporosis. These can be improved through exercise and strength training. Also, mood changes, fatigue, and hot flashes that may be common with effects of androgen deprivation therapy, also known as hormone therapy, can really impact quality of life for some men, and including impact of sleep. And metabolic changes can impact blood sugar and weight distribution, which can also contribute to cardiovascular risk factors. Next slide. So while androgen deprivation therapy up to 2 years has not been associated with increased cardiovascular death, we do know that research has shown that androgen deprivation therapy can increase your fat deposition or deposits, insulin resistance, and may also affect on the level of blood vessels like arteries. This can suggest that there is likely an increase of developing diabetes and cardiovascular disease as a result. Continuous androgen deprivation therapy used for at least 6 months in older men has also been associated with increased risk of diabetes and fractures. Next slide. So as it relates to bone health, androgen deprivation therapy related bone health is an important health issue. Men with non-metastatic prostate cancer receiving continuous or intermittent androgen deprivation therapy can have significant bone mineral density loss as early as the first 6 to 12 months after starting hormone therapy. And that can be up to a loss of 10% over 2 years. Intermittent androgen deprivation therapy tends to be a little bit better, but there's still an impact there. Next slide. So in addition to loss of bone density, loss of lean muscle in the legs can also lead to poor muscle strength and poor physical function. And these are major risk factors for both falls and fractures. Additionally, smoking and excessive alcohol use, which is defined in men as more than 2 drinks per day, are considered primary risk factors for fracture in older men. smoking is associated with bone loss in older men, and especially in those who are current moderate to heavy smokers with a low body weight. Excessive alcohol is associated with increased bone loss and has been found to have a significant effect on bone density in men with prostate cancer who are on hormone therapy. So therefore, the recommendation is that smoking and excessive alcohol consumption should really be avoided. Next slide. An active lifestyle through exercise is essential to bone health in men with prostate cancer on hormone therapy. Both weight-bearing, aerobic, and resistance exercises are beneficial in improving bone density in men and with normal bone density, and also in those who are at risk for osteoporosis. Exercise programs can include aerobic and resistance training, and they've demonstrated positive effects on the quality of life and fatigue, lean muscle mass, muscle strength, physical function, and balance in men with prostate cancer. And we know that those highlighted there, the muscle strength, physical function, and balance, are all important in improving bone density and preventing falls in older men. Next slide. So calcium and vitamin D definitely has a role. They're necessary for maintaining bone health. Vitamin D helps your body absorb calcium and phosphate, and muscle contains vitamin D receptors and may improve muscle strength and function. It's common for men with prostate cancer to not get enough vitamin D and calcium in their diet. And so vitamin D alone or in combination with calcium has been shown to be beneficial for bone density and preventing fall and fracture in older men and women. A daily vitamin D dose of 800 international units has been shown to reduce the risk of hip fractures in people 65 and older. Next slide. So general recommendations is while you are on hormone therapy to have a bone mineral density test every 1 to 2 years. And it'll be important to discuss with your doctor as to your particular health conditions if it is safe to increase your total daily dietary supplemental calcium intake to 1,500 milligrams and vitamin D to 800 international units daily. Next slide. So it's always best to get your nutrients from whole foods. We recommend avoiding supplements as much as possible if necessary, if possible. And so some of the foods that you can look to for stronger bones include broccoli, spinach, kale, mustard greens, etc. So next slide. In terms of exercise for bone health, daily cumulative duration of 30 to 60 minutes of physical activity most days of the week. And that just means it doesn't have to be all at once. It can be in 10-minute increments of activity throughout the day. Specific exercises that can benefit bone health, weight-bearing aerobic activities, for example, like walking, cycling, hiking, and dancing up to 4 to 7 days per week. And strength and balance activities, for example, weight training, stair climbing, wall push-ups, or even chair rise exercises 2 to 4 times days per week. Men with osteoporosis or at risk for osteoporosis can also do weight-bearing aerobic exercise training as appropriate for functional capacity, and that can be discussed with your doctor. Additionally, those people at risk of falls, there are certain exercises like Tai Chi that help promote balance, or even balance training, physical therapy, as well as core stability exercises, strengthening of your abdominal muscles to improve muscle strength and posture. As I mentioned, it is important to check with your doctor before starting any new exercise regimen. Next slide. Okay, healthy eating is the next discussion. Next slide. So increased protein intake and exercise are both important for maintaining muscle mass and maintaining a healthy body weight. We also talked about the role of calcium and vitamin D intake for keeping your bones strong. Next slide. So it's more important to aim for a healthy eating pattern rather than focusing on specific foods. I have patients that come in all the time that say, tell me, what should I eat? Is there something, some special superfood that's going to prevent my prostate cancer from coming back? We really don't have data to support any one specific food. It's just better to aim at an overall healthy eating pattern. So if you want to eat at least 5 servings of fruits and vegetables every day, you want to go for fruits and vegetables with deep, bright color, with the highest of nutrients, and then consider eating them for a snack, replacing, junk food. Choosing whole grain bread instead of white bread, and whole grain cereal as well. Limiting red meat, including beef, pork, lamb, and goat, and processed meat like bologna and hot dogs. Fish, skinless poultry, beans, and eggs are probably healthier sources of protein that you can look to. Choosing healthful fats like olive oil, nuts, avocados, and then limiting saturated fats from dairy and other animal products, as well as trans fat, or reading fast foods and packaging of processed foods, avoiding those types of things. Also avoiding sugar-sweetened drinks such as sodas, and saving fruit juices and things as an occasional treat. It's also important to cut down on salt and limit canned, processed, and foods as able. And watching your portion sizes, eating slowly, and really stopping when you're full, not aiming at finishing whatever's on your plate. Next slide. So exercise, next slide. Physical activity can improve not only your physical but emotional health. It's important for managing weight, maintaining muscle, and reducing the risk of heart disease and keeping bones strong. Staying active can also help with your balance, improve your sleep, reducing fatigue and anxiety, and help with potential side effects of prostate cancer treatment. As we talked about, hormone therapy may impact sleep. Declining or low physical activity is associated with an increased risk of fracture in older men, likely due to loss of physical function and bone density. Poor physical function itself, such as difficulty rising from a chair, walking, and balance tasks, is associated with low bone density, as well as bone and hip fractures. Men with prostate cancer receiving androgen deprivation therapy can really maintain muscle strength and physical function through an active lifestyle. Next slide. So muscle burns up to 50 times more calories than fat. So if you increase your muscle mass with strength training and aerobics, you will actually raise your resting metabolic rate. And that can not only prevent weight gain, but it can also help you lose weight. Strength training, also known as resistant exercise, can help you increase muscle mass and is also important for maintaining healthy bones, as we discussed. Types of strength training may include weight training, push-ups, and pull-ups. You probably want to avoid crunches, which can aggravate leakage that may be due to stress incontinence from prior surgery or radiation. Aerobic exercise such as fast walking, dancing, hiking, swimming, etc., causes the calories you burn to increase not only during your workout, but for a few hours after the workout. And it's important to remember that physical activity does not only include just working out at the gym or playing sports, but even engaging in hobbies that you enjoy around the house, gardening, bicycling, dancing, and doing regular household chores, parking a little bit further away if you're able to in the parking lot, climbing stairs when you can, those types of things. Next slide. So as mentioned, in men with prostate cancer, physical activity is associated with better survival, and even a modest amount of vigorous activity, about 3 hours a week, can substantially improve prostate cancer survival. Any plan for physical activity should fit your personal situation and fitness level, and it's important to talk with your medical team before starting any exercise regimen. You can ask them about the types of exercises that are right for you, the intensity that you should aim for, and how often and how long you should exercise. Next slide. So in summary, it's important to choose a healthy diet, avoiding sugary drinks, limiting processed foods high in added sugar, low in fiber, or high in fat, eating a variety of vegetables, fruits, whole grains, and legumes, such as beans and peas, limiting red meats and avoiding processed meats, limiting alcohol drinks if you consume them at all to 2 or less per day, limiting consumption of salty foods, and not relying on supplements to prevent or protect against cancer, but really looking at a well-rounded whole diet. In terms of maintaining a healthy weight, if you are overweight or obese, definitely try to work on losing weight. If you are at a healthy weight, work to maintain it through exercise most days of the week, choosing a healthy diet as above, and then staying active. Exercising, as we said, regular exercise can decrease your risk of developing heart disease, stroke, and certain types of cancer. It can also contribute to overall health and improve risk of recurrence of prostate cancer potentially. If you don't already exercise, it's important to make an appointment with your doctor to make sure that you have a plan for getting started and that it's safe for you. And that will be it. Next slide in closing. This is just a closing slide. Thank you very much for your time. This is my German Shepherd Apollo, who enjoys his cucumbers. Thank you.
Thank you so much, Dr. Moore. Next, we welcome Dr. Chris Walter, Assistant Professor of Urology and the Urology Residence Program Director at Mayo Clinic, who will lead our discussion on urologic complications and sexual health.
Again, my name is Dr. Chris Walter. I'm a reconstructive urologist. Next slide. And so I don't have any relevant disclosures to this talk. So why choose me for this talk? I don't treat prostate cancer, but my practice scope is exclusively focused on incontinence, impotence, voiding dysfunction, and what's called urologic reconstruction. So I don't treat prostate cancer. I just have a referral practice for a large catchment of is the complications from prostate cancer treatment. I feel I don't have any bias in my practice because I haven't caused the problem. I just fix it. Next slide. The treatments of prostate cancer that are available are numerous. Dr. Tyson had talked at length about surgery, and Dr. Killey talked a lot about radiation therapy. There's also things like cryotherapy, HIFU, hormonal manipulation. That's a mouthful there. And watchful waiting, which isn't really doing nothing, but it's just close surveillance of the prostate cancer with your urologist. Next slide. When you have treatments, though, there are side effects. For surgery in particular, erectile dysfunction, I use the general term 30 to 70%. You probably can't find a reference specifying that exact number, but that's just kind of a gestalt we have now. Estimates can vary widely, and it just really depends on the patient population that you're studying in a lot of cases. It can be anywhere from as low as 5% in very low risk individuals to as high as 85% in high risk individuals. Incontinence is another and probably more devastating side effect that men can get after prostate cancer treatment. It is reported to be about 3 to 10% in general, and this is long-term incontinence. This is not the acute stuff you're going to see right after surgery. It's likely overall higher in varying degrees, but a lot of definitions, again, are just as good as the people defining them. And so a lot of surgeons will deny that patients are incontinent if they're just wearing what they call a safety pad or something that would catch leakage, but they're not really seeking active treatment for it. Generally speaking, urinary habits will change in the vast majority of patients after prostate cancer therapy. And this not to mention the complications of surgery when you're concerning that. It's a major procedure, and the risk is always present of something that could happen. It's definitely not zero. Next slide. Radical prostatectomy recently, in the last 15 years, has been revolutionized by the Da Vinci robotic system. There are also open approaches, of course, but this is the overwhelmingly most common treatment chosen when we're talking about surgery. It has definitely been a game changer in terms of getting the patients out of the hospital faster and reducing blood loss. But even with these advances, you can still have complications down the road and the side effects of prostate cancer treatment. Next slide. Radiation therapy is, as we had discussed earlier, externally delivered or implanted X-ray energy to the prostate gland. And there's a variety of modalities that this can be given. Next slide. The side effects of radiation, there are very rare side effects early on. Erectile dysfunction can be in as few as a quarter or as many as half of patients, depending on their pre-treatment status. And that's a side effect, though, after 5 years, and could even be higher. Incontinence is widely reported. Up to 20% experience a change in their urinary habits. You can see changes to the urethra, and radiation to the bladder can also cause irritative changes as well. And there can be bowel side effects and the risk of secondary malignancy, as also mentioned before. Next slide. Erectile dysfunction, radiation will show late changes to the penile nerves and the nerve supply. And again, you can have ED in up to half of patients. Incontinence and urinary symptoms are common in patients while they're going through treatment in the acute phase, but these do dissipate and then can show up later after time. These are mostly what we call irritative symptoms, so that think more like the urgency to go to the bathroom, frequency of urination, things like that. Obstructive symptoms can also happen acutely. This is usually due to just some swelling of the prostate or some difficulty of the patient letting go of the urine. And this usually returns to baseline about 2 months after surgery, or I'm sorry, after radiation therapy. Years later, the later sequelae can develop, however. Next slide. So why am I speaking today on this? It doesn't really matter how the problem got there. It does exist. And so that's what people like me in our kind of practice are here for. Patients are often surprised at the presence of a side effect, and they can actually be quite devastated by it, really. This is often due to a case of it's not really discussed in full with the surgeon. Either too little info was given, or the patient has too few questions going into it, which is, understandably, the emphasis is on prostate cancer cure early on. So that's usually not where a lot of people's heads are when dealing with these problems, especially when they're faced with a cancer diagnosis, and sometimes a very serious cancer diagnosis. Next slide. The side effects of treatment can have far-reaching implications. So what does this mean? Patients who are incontinent or who develop erectile dysfunction, it can change their relationships. It can affect marriages. It can affect the patient's social relationships. If they're worried about leakage and they're out in public, that really will change their behavior patterns. Their self-image can change. This can lead to depression. It could lead to a change in activities, lack of exercise because of fear of leakage. And a lot of men carry regrets for getting treated, and they wish they would have known more before going through this. This is one of the most common conversations we have to have with patients when they're coming in for one of these problems. And it's good to bring them back to the fact that it is really important that you did get good cancer treatment first and foremost, and that we can deal with the side effects of this later on. Next slide. So erectile dysfunction, we'll start with this first because it's probably the most common side effect of the treatments that we're going to deal with today. Most men who get treated for prostate cancer are often of an age when erectile dysfunction begins to naturally develop. So this is obviously in the 6th and 7th decades of life, so patients in their 50s and 60s, where the erections might naturally start to soften, and up to half of men or more. Even with perfect pre-treatment function, erectile dysfunction can still develop after a perfect operation. So we talk about perfect nerve sparing, negative margins, all that good stuff happens, but patients still have erectile function changes when they state upfront that they were totally normal beforehand. This can be very frustrating for both the patient and for the surgeon, and it can sometimes strain the relationship between them as well too. So it's important that we have means to get this addressed. Next slide. Erectile dysfunction treatments, a lot of these are very common in the cultural knowledge now too. Medications are, almost a household name: Viagra, Cialis, Levitra, there's others, Stendra. They're effective for sure, but they're probably less effective after a radical prostatectomy. And the success of these medications really requires intact blood flow and intact nerve supply to the penis for them to really work their best. Their mainstay, we'll employ these in, is something called penile rehabilitation, which will put men through a process of this. Injection therapies are also available. Yes, this means giving yourself a shot in order to obtain an erection. It's a vasodilator, a medication that will dilate the blood flow to the penis. It's not tolerated by everyone. The injection itself can be painful, but it is actually a very potent form of therapy. So if it works, men can almost have normal erections even after a radical prostatectomy where they were completely impotent without any assistance. Vacuum erection devices are also available. These can be quite cumbersome though, and it does require a patient and very understanding partner, but they are kind of a turnoff to a lot of patients, but they do serve a purpose for sure. Next slide. Penile rehabilitation, revisiting this. So this is when you're going to take either Viagra, otherwise known as sildenafil, or one of the other medications mentioned, usually 3 to 7 times per week, starting 2 to 4 weeks after surgery. So once the catheter's out, patients are up and moving around better, and they're starting to mobilize their activity a little bit better. This has actually been studied quite extensively. Those who are on penile rehab 2 to 5 times more likely to regain erections suitable for intercourse, and more than half treated were still impotent though. So it's not perfect, but it definitely does help. It's a good starting point, and there's enough success to be taken very seriously with this. So we do advocate for our patients, if they're really concerned about erectile functions, to be started on these medications at an early stage in some regular fashion. Next slide. Surgery for erectile dysfunction is one of the main things that I do as part of my practice. The mainstay really is overwhelmingly the inflatable penile prosthesis. There are also malleable prostheses available, but the 3-piece inflatable is probably the most common and most effective surgery that we'll do for erectile dysfunction after prostate cancer surgery. As you can see, it's a multi-component device. Everything is custom size and fit for the patient at the time of surgery. These come in multiple sizes. There is a fluid reservoir off to the right, and then a pump that actually gets implanted in the scrotum that is the means to control the inflation and deflation of these cylinders that get implanted in the penis. Next slide. So this is a better depiction of what it actually looks like in the body. This goes in through a single incision. The incision is only about 1 inch to 1.5 inches long. Usually it's either at the base of the penis, right on top of the scrotum, or it can go at the base of the penis on the other side, right at the level of the pubic bone. There's 2 different approaches. Again, the fluid reservoir gets implanted into the abdomen, and then the pump you can see is down in the scrotum next to the testicles. Everything is concealed completely. Cosmetically, it's very acceptable. You would not know somebody had one just by looking at them. So it does maintain that sense of self-esteem for the patients, knowing that they can be more potent. Next slide. Again, the 3 parts: the cylinder, the reservoir, and the pump. And again, the important thing is that this is totally under patient control. This goes a little bit beyond the scope of this talk, but they're even talking about ones that are going to be controlled through like a key fob or a phone app. So more to come on this in the future, but that's probably still 5 or 6 years away. Next slide. The penile implant versus other forms of treatment for erectile dysfunction is actually very high in terms of satisfaction. You can see oral medication patients after prostate cancer surgery, really only about half of them are satisfied. Penile injection therapy, even less so, despite the fact that it's a more potent treatment. It's a real turnoff for a lot of guys to have to give themselves a shot. But the penile implant, that 93% is probably in the high end of what's reported, but you can see anywhere between really 85 to 90 something percent satisfaction with that as a form of erectile dysfunction treatment. Next slide. Again, of all the ED treatments, the highest satisfaction rate mainly is due to the rigidity that you achieve and how discreet it looks once it's implanted. It's also a very reliable device. These things have gone through great advances in materials. Not only the safety of the operation itself in terms of infection control now that we have antibiotic-coated devices, but the materials themselves are extremely durable. And I confidently tell patients that they should expect 10 to 15 years of device longevity when they get one of these implanted, as long as it doesn't have any injury to it or something like that, which would be pretty unusual. The manufacturers, there's only 2 of them in this country being sold. They actually give lifetime guarantees to the devices. which I think the guarantee is, this is a little tongue in cheek, it's a little bit worthless because they're not going to hand you another one in a box and say, hey, sorry about that, but you do have to get another surgery. But they do have great confidence in how long these things can last. However, next slide. This is still a surgical procedure. And so patients have to go through about a 6-week healing period just to be able to use the device afterwards. Nobody's going to be healed up enough or not sore enough to be able to use one of these right off the bat. And mostly that's due to the manipulation of the pump and the scrotum. There's going to be a lot of swelling and bruising in that area after the surgery. So it can be a little bit of a turnoff for patients, and some do have a little bit of regrets afterwards, just because of the recovery process. But more than half of patients have minimal pain after this operation. It does require good manual dexterity, so we do have to screen patients pretty hard for who's appropriate to get one of these. You don't want to put one of these in somebody who's too frail or too old. A good way of judging this before was how firm their handshake was. Now in the COVID area, we can't really do that, but I still have to do some dexterity and hand strength tests with patients just to make sure that they will be able to function with one of these afterwards. Otherwise, they have to have a committed and willing partner to help out with it. There are risks, again, with any surgery. Infection is a devastating risk, and it is devastating when it happens. It's now only about 1% on primary implant cases, but again, it can be quite catastrophic. It requires complete removal of the device, and any subsequent surgeries, even a replacement of the device, carries a much higher infection risk in the future. And again, we talked a little bit briefly about breakage of the device. These things are man-made, they can break. So one has to be careful in certain situations. And sometimes they break for no good reason, just a part wears out. One of the cylinders or the tubings snaps open, and all the fluid in the system will discharge from it, and then it's not useful anymore. Another interesting fact is that about 15 to 20% of men who get one of these never actually end up using it. Sometimes they're done just in case. They need it for their self-esteem. Sometimes their spouse or partner develops issues down the road that prevents sexual intercourse from being possible. So I always inform men there's about a 1 in 5 to 1 in 6 chance that this might not ever get used regularly. Next slide. All right, moving on to the next and probably the more devastating of side effects would be incontinence. Next slide. So normal continence, the question always I'd like to start off with is how does it actually work? So the bladder has really two functions. It fills up and it stores the urine. So that's where the urine collects, and then it eliminates the urine. And so what we have here in men after prostate cancer treatments is usually a failure of storage. And that can be a big issue for a lot of men. The sphincter muscle is usually the thing we focus on the most. It's a circular muscle at the level of the tip of the prostate that controls the flow of urine. So you can see no matter how the prostate cancer is treated, the sphincter is in very close proximity. So it's very likely to get infected by whatever treatment there is. And even patients who go on androgen deprivation or hormonal therapy are not free from risk of sphincter function changing, because it is what's called a rhabdosphincter, which means it's a skeletal muscle, and that can atrophy with either age or with androgen deprivation. So these things are all something to consider. A healthy sphincter will stay closed until one relaxes to urinate. So what you have in these patients is either one that can't close tight enough, or it doesn't close at all. Next slide. Normal continence can take up to 18 months after prostate cancer treatment. And here we're really specifically talking about surgery. Generally, 1 year after surgery is when most men are about as dry as they're going to get, but you can have additional benefit for another 6 months or so. Overall, about 3 to 10% of men will develop incontinence, and that means treatable incontinence after surgery, depending on what category of man you're talking about. But most men will have it at some point, and so they really know what to look for. Especially after prostate cancer surgery, a lot of men will have leakage for up to the first 3 months. I would even say the majority of men do. And then normal continence and dryness starts to really take off after that. Most men can get by with just wearing a small pad just for safety. A lot of men just like to keep something in there, even if they consider themselves to be dry or completely continent. Others never urinate normally, and they will continually leak into diapers, and it's quite devastating for them. Next slide. This is less common than erectile dysfunction, but again, we said it's more devastating. Specifically to radiation, you're going to see more of what we called earlier the irritative symptoms. It's more like overactive bladder, so going too frequently. This can be a little harder to treat, and sometimes we have more limited options because we just can't do a surgery, as I'll explain for some of the stuff that we do after radical prostatectomy. But there are definitely treatments available for that. The problems that men get with the incontinence, of course, they can have staining of their clothes. They can become reliant on diapers or pads. It's going to prevent them from doing normal activities, either exercise or golfing or social activities. And it really limits their comfort outside of what they consider to be their safe areas, which is usually their home. You can also get skin breakdown, skin changes from constant exposure to urine, rashes, dermatitis, things like that. Men can develop an odor, which becomes very bothersome to them and their spouse. And really, again, it can affect their self-esteem considerably. Next slide. So the treatments are broken down into non-surgical and surgical. Really quickly about the non-surgical ones, these are things like behavior modifications. Men will limit their fluid intake. This is not necessarily a great treatment for them, or they'll really time their fluid intake. Kegel exercises, so that's squeezing of the pelvic floor muscles in a regimented fashion, just like any other exercise to build up the muscles. Biofeedback can be employed. Medications are available, but this is more just for the overactive bladder side of things. There are really not any effective medications for stress incontinence, which is the leakage that most men get after surgery. Again, for the irritative things, Botox injections. And then we have devices or contraptions like external clamps, diapers and pads, of course, and external continence devices. The surgical options, really the mainstays are going to be the artificial urinary sphincter and the male sling, which we'll go into detail in a second. And then there's also things like bulking agents that we can inject into the urethra to fatten it up a little bit so it doesn't, so it closes down. And then there's historically, there's been urethral reconstructions, which are actually very high failure and many side effects. And I don't think there's really any role for those in contemporary practice right now. Next slide. External continence devices, these are exactly what they sound like. They're continence devices worn on the penis. They're almost like, some of them are almost like a little mini diaper that can go on the outside. Others are collection bags. These are good for people who are not sure about surgery or who just want to get by in that first year after their prostate cancer treatment. Next slide. Here you can see an example of an external clamp. These are disadvantageous because they can cause, they're bulky, they can cause pressure changes to the skin, and they're generally not a turn on, and they can be quite uncomfortable if worn for a long time. Next slide. This is an externally applied device that can go on. This basically affixes to the tip of the penis and goes into a drainage bag. There's, again, also pad-like devices that will go on there. The surgical options for stress incontinence are the male sling and the artificial sphincter. Next slide. Thank you. The male sling, this is going to be your less invasive option overall. This is better suited for mild cases of incontinence, though. These are men who go through anywhere from 1 to 4 lightly soaked pads per day. Most of us who do implantation of these have somewhat of an algorithm that we go through based on the exam and then findings at the time of endoscopy of the urethra, where we can gauge whether or not patients would be a good fit for this. So patient selection becomes very important for these. You don't want somebody who's going through 6 diapers a day to be disappointed when you promise them that a male sling will make them dry, when it's really not going to do that for them. It's minimally invasive, though, and it restores the normal position of the urethra and it improves the natural sphincter function. So it is just set it and forget it. We implant these things in men, and they're dry from day 1 after surgery. All they have to do is recover from a pretty minor procedure, and they should be good for a long time after that. Next slide. This is the way it goes. This is what the sling actually looks like. It's a polypropylene mesh implant. And there are these helical passers that help implant it, and you'll see in the next slide. Next. It goes around the pubic bone, so the needles that I showed you before will actually go from an inside to out fashion right alongside the urethra, and then curve around the pubic bone, and then we use the bone as a fulcrum, and we pull on the arms of that mesh, and it draws the urethra further inside, increasing the amount of resistance up against the external sphincter. And generally speaking, we have really good improvement and what I would consider cure in about 75% of men. And the less their incontinence is to begin with, and this is of course very intuitive, but the less their incontinence is to begin with, the more likely they are to stay dry. It's a great option for mild incontinence, as mentioned before. And so it doesn't really compress the urethra, it just lifts it up. So urination is unchanged. They can empty just fine. Next slide. The artificial urinary sphincter is what we consider to be the gold standard of treatment. This has a long history of success in various forms. It's been around for almost 40 years. Cure rates are reported about 85% of men. It's probably higher than that, but it just depends on how severe the incontinence is to begin with. Many men are pad-free, and generally speaking, the vast majority, I'm talking 90+%, are greatly improved as what they would consider themselves. It allows for spontaneous urination, but you'll see in the next slide, they need to manipulate a pump. And this is the device here. This is what it looks like outside of the body. Again, 3 components: a fluid reservoir, which is actually pressurized to keep the fluid pushed into the cuff; a control pump that again goes into the scrotum. And yes, these are made by the same company as the penile implant, and they were actually invented by the same person. And then the last thing is the cuff that goes around the urethra to compress the urethra. Next slide. This is how it looks like when it's in the body, again, in the scrotum, wrapping around the innermost part of the urethra that we can safely reach. And this is actually done through 2 small incisions. You do need to control the device, so men have to be awake and alert and capable of operating this just like the penile implant. But again, urination is much more common occurrence. But again, it's all hidden well in the scrotum, but the men have to get the urge to go and then pump this device open, and then it will refill all by itself. Next slide. The future of therapy. Right now, there's the only major thing that we're excited about that might be coming down the pipeline would be injected muscle cells. These would be harvested from the man's own body and then injected around the urethra. We're already starting to do this in women. Hopefully we can get this down right in men. It's not offered yet, but there will be clinical trials hopefully forthcoming. So on to my next and last slide. I look forward to your questions, and thank you for your attention.
Thank you so much, Dr. Walter, and welcome to our panel discussion. If Drs. Moore and Walter could join us. And we also have Dr. Hala Borno on behalf of the Prostate Cancer Foundation joining our panel. So to start again, I just want to kind of open this up to some questions from the audience, which we've been getting. To start, Dr. Moore, are there any supplements that are helpful in patients who are doing active surveillance?
In terms of active surveillance, there's no studies that have shown any one supplement or any one food that is causing a significant enough decreased risk to add to your regimen at this point. I think the importance with active surveillance is just continuing that close interaction with your healthcare provider and monitoring of the PSA.
Okay. And Dr. Walter, someone has asked, is there a vascular surgical procedure coming on for venous erectile dysfunction?
I'm sorry, you cut out a little bit on that last part of the question.
Yeah, so is there a vascular surgical procedure coming online for venous leak erectile dysfunction?
A vascular procedure. So there have been historically attempts at doing that for venous leak. Generally speaking, they haven't really been that successful, and they can be quite invasive in morbid operations. I don't know if they're commonly done anymore. I think there might be 1 or 2 surgeons in the country who are still doing them, but really it's never really made mainstream success.
And so we have a question about bone pain with metastatic damage. What can be done for that damage other than medications?
So in terms of metastatic bone disease, we do have bone strengthening agents that are sometimes used, especially if you're in a setting where hormones are no longer as completely effective in controlling the prostate cancer. If you have a significant amount of bone involvement, there are treatments like radium, which can be utilized to help with the bone pain. And then obviously supportive care, sometimes with the assistance of a palliative care team to manage that for bony pain and metastatic disease.
Okay. And Dr. Walter, a patient has asked, how long does a penile prosthesis last?
I tell my patients 10 to 12 years. Again, I did allude to they do get a lifetime guarantee from the manufacturer, but as I said before, I think that's not really useful because it requires a repeat surgery if something breaks. 10 to 12 years is pretty common. If you really break that down, if you go down to 5 years, there's still probably about a 15 to 20% rate of either breakage or needing to adjust the device or something, along, again, one of the patients who has one explanted for infection can be a problem. So if everything goes right, it doesn't break, again, 10 to 12 years before they start wearing out, typically.
Okay, and then we had a follow-up question. Is there any malfunction associated with that?
You cut out at the last part there again, I'm sorry.
It's a follow-up question. Is there any malfunction with that implant?
Is there any malfunction that is?
With a penile prosthesis.
Any malfunction. So the good thing with the malfunction, or there's two things that can happen. Number one, and this has largely been engineered out of the devices, so it's fortunately not very common anymore. But you can get something that's called autoinflation. It used to be quite common. It would happen if it's exactly what it sounds like. The man would get an erection when they didn't want one. They put lockout valves on these, either in the pump mechanism or in the reservoir itself, to prevent this from happening. But that would be one of the main ones I could think of. Again, it doesn't happen nearly as often as it used to. Sometimes even the capsule surrounding the reservoir could become fibrotic and it would just empty the fluid or be under too much pressure. The other thing that can happen, though, is if one of the components breaks, it does technically malfunction because all the fluid will drain out of the system. Then it has no power, essentially. So you can pump and pump and pump all you want, but there's nothing in it to make it go up. That would be the main malfunctions I could think of.
Okay. And so I have a question kind of back to diet. What is the common opinion on the keto diet to try to manage physical health?
I'll take that. So I would say at this time point, there's not a high level of evidence to support, restriction to the keto diet. There are certain food groups that have been shown to be beneficial, and most of these data are relevant to the localized disease setting. So not necessarily applicable to patients with more metastatic disease, but in the localized disease setting, studies that have come out of Harvard have shown that cruciferous vegetables, fatty fish are beneficial foods to incorporate into diet and actually have been shown to have an association with survival and outcomes for men with prostate cancer.
Great. Dr. Moore, did you have anything to add to that?
No, that's fine. I would agree.
Okay, great. And so we also have a question asking if there are any supplements that can help with erectile dysfunction.
Generally speaking, I would say probably not. I don't know if anybody else has anything to weigh in on this. What you want to really consider in this is what we consider to be really anything healthy, whether it's a cancer healthy diet, prostate cancer healthy diet, erectile dysfunction healthy diet. It's really what's a cardiac healthy diet. So think along the lines of the Mediterranean diet, something that is anti-inflammatory, a lot of antioxidants. But I wouldn't recommend any one specific agent. There's other things to consider, like your hormonal status and things like that. But I don't know if anybody else has anything to weigh in on that.
Nobody else? Okay. So kind of back to another diet question. There's a few doctors who have advised not eating any animal products, especially eggs that have a lot of choline. What are your comments on whether or not patients should be eating animal products?
The studies that came out of the Physicians' Health Survey looked at whether or not men were eating high levels of red meats, and that was associated with worse outcomes. And so that supports sort of reducing red meat consumption, but that's as specific as I can get in terms of what the data shows us today.
Okay. So Dr. Walter, we have a patient question. Does there need to be a percentage of nerve sparing after robotic prostatectomy for erectile dysfunction to be effectively treated?
Fortunately, no. You can do completely non-nerve sparing, and we can treat the erectile dysfunction in any varying degrees. I mean, it could require, again, this is going to be less common, of course, but it could require something as little as Viagra or Cialis. But even in a totally non-nerve sparing operation, we can do a penile implant if they're completely impotent and nothing else works. So the degree of nerve sparing is going to influence recovery more than anything. But again, it's not absolute.
Okay, great. And so I've been asked, what are your thoughts on antioxidant supplements on patients that are on hormone therapy?
I would say for patients that are on hormonal therapy, there's not sufficient data to support use of antioxidants. I think that the strongest data is in support use of calcium and vitamin D as the supplements of choice for patients on hormonal therapy.
Okay. And Dr. Walter, how long will an artificial sphincter last?
Artificial sphincters don't last as long as the implants, is what I had said before. Generally speaking, I will say 7 to 10 years effective lifespan of an artificial sphincter. I think this is probably one of two reasons. Really, you're using it 5, 6, 7, 8 times a day, however many times you're urinating. So there's a lot more use than a penile implant would get. The structures of it are more delicate. The balloons are thinner, so they're a little bit more prone to breakage. The other thing, though, is that thing is constricting the urethra the majority of the day. What that will cause over time is the urethra to get thinner and thinner and thinner and thinner until there's really nothing left but just the lining of it to squeeze against. And that's really not effective in preventing the leakage from happening. They can, like I said, they can also break too. But so generally, most patients, if done properly, 7 to 10 years is expected. That number goes down if they've been radiated, though.
Right. Okay, and so we have a 70-year-old patient on ADT with osteopenia. He's asking if cycling is okay, and should there be a concern for risk of falling?
So I would say absolutely cycling is okay. Vigorous exercise is a good idea if you can tolerate it. And then if you have evidence of osteopenia on your most recent bone density, then I would recommend incorporation of resistance training, lifting weights, dumbbells, to really help strengthen the bones, and then the addition of calcium and vitamin D as well into the regimen.
Great.
And to answer the question of fall risk, I would say there is no known additional risk of falls driven by the osteopenia alone. However, hormonal therapy can reduce muscle bulk, and then weakness can increase your risk of falls independently of the bone density.
Right, definitely. Dr. Moore, did you have anything to add to that?
No, additionally, to answer the question about falls, was increasing exercises for core and balance exercises as well, just in general, but nothing, again, I would agree, as it relates specifically to the osteopenia, that would increase the risk of falling with bicycling, other than thinner bones if you do fall.
Right. Okay. And Dr. Walter, so with a penile implant, does the man still feel pleasure when he has an erection? And will the orgasm resemble a pre-RP surgery?
So yeah, the good thing is about the implant techniques, we are very good at sparing the nerves in terms of the ones that control sensation of the penis. So either approach that we implant surgically, sensation should remain intact. I will go on and say though that it does feel different for men, especially in the beginning after having one of these implants. Sometimes it doesn't feel like part of their body initially. Most men, that does kind of feel that way afterwards. Climax is different with anybody after prostatectomy because they can't ejaculate anymore, but they can still have that pelvic floor muscular rhythmic sensation of having an orgasm. It'll just be dry. Nothing will come out, of course.
Mm-hmm. Okay, and so we also have a question about loss of taste. Dr. Moore, is there any recommendations you have if a patient's experiencing loss of taste?
No, there are some medications that can cause loss of taste as a side effect. Unfortunately, I don't think we have anything specifically to augment that. If it's not related to dry mouth and whatnot.
Okay, definitely. And so, Dr. Walter, so obviously, sexual health is sometimes something that's hard for people to talk about. So how can we help to encourage men to talk more openly about these issues if they're experiencing them?
So I missed the very first part of that. I think we were talking about, it's telling me my internet connection's unstable now, but the initial part, I think, was just about, was it just about the sexual function or both the problems?
So if there's any kind of sexual issues, how we can kind of encourage men to talk about them a little bit more openly.
I think a big thing up front, and I think most urologic training now is doing a good job of emphasizing this, is just pre-education before prostate cancer surgery. And if the patient is in a relationship, to have their spouse or significant other there with them every step of the process, because again, this is something that really can affect the intimacy here. Otherwise the I think patients should feel empowered to talk to their surgeon, whoever did their prostate cancer treatment, or even their oncologist or radiation oncologist. They're having difficulties, to put them in touch with the right people to help deal with this. The other thing is there's support groups available. One of the ones that I frequently contribute to locally here is something called US2, which is a national organization for prostate cancer support. But there's other ones out there as well, that are often hospital by hospital. And I think, some resource along that lines really can open the lines of communication for men and give them the tools and the power they need to move forward with bringing that discussion to their doctor.
Okay, definitely. And we had another question come in about debulking surgery. How should my debulking surgery balance continence with the reduction of the tumor, which is now decreased to 3 centimeters after chemo?
I would say this is probably, if the patient hasn't had radiation, and we're just talking about chemotherapeutic or some kind of oncologic reduction here, I would probably say that if they had significant enough disease to have pre-treatment before surgery, that they're probably not going to get an aggressive nerve sparing operation, and they should probably expect to have some difficulties with incontinence. It doesn't necessarily mean it's going to be long-term, but they might have a more protracted recovery than the average patient after a radical prostatectomy. And if they've had radiation, if that's how they're shrinking the gland or getting local control first, I would say it's not 100%, but it's a very high percentage of men are going to have incontinence after a salvage prostatectomy.
Okay. We have another question. Should patients consider seeing a nutritionist?
I would say that it's always helpful to include a nutritionist discussion for information and resources if the patient has the access to that, especially not only from the standpoint of questions specific to their prostate cancer diagnosis, but also general health, as we talked about, limiting of comorbidities, diabetes and hypertension, those kinds of things can ultimately result in better outcomes. So I would encourage that if a patient is interested in speaking with a nutritionist.
Okay. We also have someone who asked, what are the effects of prednisone on weight?
So prednisone can lead to weight gain through a variety of mechanisms. One mechanism is that it just increases appetite. And so patients end up eating more and put on weight through that way. The other way is that it can lead to some fluid retention, so that patients carry water weight, and as the result can gain weight through that pathway as well.
Okay, great. And so just to bring it all together, we just have time for one more question. Do each of you have any resources that you could offer to our patient audience today, pertaining to health or sexual health and incontinence and things like that?
So at the University of California, San Francisco, where I practice, we do have patient lifestyle guides that have guidance on food groups, and I'll share that with you, Christy, and you can share that with the audience.
Great.
Yeah, I would say, and Cassandra's response will probably be similar to this. The Mayo Clinic's website, mayoclinic.com, has a lot of patient resources to be able to look all this stuff up. Everything I talked about there is present in available treatments in some form. So that would be a very good jumping off point there too.
Okay. And Dr. Moore, did you have any to add?
No, I would agree. That's as he said.
Okay, great. Well, that is all the time that we have for this panel. Thank you so much, Dr. Moore, Dr. Borno, and Dr. Walter. We really appreciate it. It is now my pleasure to introduce our summit chair, Dr. Alan Bryce and John Litton, a prostate cancer patient. Our duo today will be discussing PARP inhibitor clinical trials, as well as John's experience on such a trial.
Hello, everyone. Very nice to be here today. Thank you for tuning in for this summit. I hope you're finding it, valuable and informative. It's my pleasure to be here today with John Litton. Mr. Litton, John, longtime patient of mine. Also, at this point, good friend. We've been doing this a while. We've been through quite a bit together, and Mr. Litton is a passionate patient advocate. He's been on this prostate journey quite a while, and if you've had a chance to go to the lobby, the e-lobby on this summit, and go to the exhibitor hall of the Clovis website, you'll see a video that he's put together with some background, his journey, and he definitely wants to pay it forward to all of you, to other patients, to really be an advocate as well as a pioneer in finding better treatments for prostate cancer, right? Our shared passion is to cure this disease. So I'm gonna stop there. I don't want to go on too long. I really want to give John, you the floor here. If you would please, talk to the attendees about, I guess, your journey, about how you navigated through making decisions about your prostate cancer treatment, and ultimately, I guess, what brought you to the clinical trial of rucaparib in prostate cancer, and your experience with that. You're on mute there. Still on mute. Let me see if I can.
There we go. Can you hear me now?
Yes.
Hi, Dr. Bryce, and to the audience out there, my name is John Litton. And as Dr. Bryce just said, he and I have been on a very interesting journey. My metastatic prostate cancer was first diagnosed 11 years ago. And I came to the Mayo and into the care of Dr. Bryce that's going on 8.5 years ago now. And I know, I guess from experience, how many of you as patients are feeling. There's a great fear about what's next, or am I doing the right thing? And I can reassure you that putting a lot of trust in your oncologist is very important, number one. But secondarily, the proof is in the different trials. And I have, at this point, been through 3 different human trials through the Mayo. So, you know, with the beginning, the Zytiga, the background Provenge treatment, the really heavy chemo infusion. Those are all different periods of things that I've been involved with. And it was actually Dr. Bryce who led me into the idea of going into the human trial for the PAR inhibitor. And that's something that I immediately, I always go right to my computer and I try to digest as much information as I can find about the different new techniques. And this one I thought sounded very exciting. Just like any other trial, there are side effects, and I've had a couple. But of all the human trials to date that I've been involved in, the rucaparib program has offered probably the best day-to-day feel of normalcy that I think a person could have and have this prostate cancer. And the side effects have been virtually minimal with me. Dr. Bryce, through a period of now going on for over 14 months being involved with this, has done different dosage changes for me, but yet each dosage reduction that I've had has eliminated maybe the potential of a side effect, but it has not done anything other than prevent my cancer from showing in any of my CT bone scans. And I am just thrilled with so far the outcome of the PAR inhibitor. Does that explain, I guess, where we're at today?
Absolutely. I mean, it's, you know, you're obviously a very experienced patient, right? As you say, you've always done a lot of research, right? You try to be very engaged in your own care. Can you talk perhaps some about the, you know, the support system you have around you? You know, I know these answers, of course, but you know, the support system around you, how you gather information and kind of decide that, you know, clinical trials is something that you want to be involved in as well.
Well, I would tell you right off the bat, I am an extremely lucky man because I have a daughter who's turning 39 next week, who runs an emergency room in Eureka, California. She is a registered nurse. And as soon as I got involved with the Mayo, of course, I gave her my passcode and that sort of thing to my patient portal. So I have a nurse who is watching over everything that happens to me. The best part, she's never tried to second guess Dr. Bryce. She's been very supportive of the decisions that we have made jointly, Dr. Bryce and I. And, you know, I say I'm lucky because I feel like I have just another set of professional eyes looking at everything that I'm doing, the choices that I'm making. I do live by myself. I'm here in Phoenix, Arizona. I spent over 50 years living in Sitka, Alaska. That's where home has always been for me. And I made the conscious choice to come down here to be closer to the good medical treatments that I could receive. And that's why I have been available to do whatever was suggested as it relates to human trials. I've been active in that arena, and I just hope that from the time that I've invested into it, that there's been learning on the other side of improvements and things that are helpful. The one thing that I do want to mention, and I think it's helpful to patients out there, if you're not familiar with the Rubraca or the PARAB inhibitor, the PARAB is an enzyme, and your cancer cells typically are missing part of the gene, and the PARAB is an enzyme that allows that cancer cell to rebuild that gene in fullness, so then it can move around and do you damage in your body. And the PARAB inhibitor does just exactly that. It inhibits that enzyme from allowing the cancer cell to regenerate itself, and the cancer cell dies. And so that's kind of the mechanism of how it works. And I'm hoping that the information here helps put your, as a patient, your mind kind of at rest as to how it's a very unique, effective way to approach cancer treatment.
Yeah, no, it's wonderful. And if I can give a little background for the people listening, I mean, when you went on this study, as you know, and we talked about it early on, your cancer had the specific mutation, right, in the BRCA gene,
Yes.
that would make a PARP inhibitor a really rational choice, right? The mechanism that you described, it fits. The cancer had a key weakness that we'd identified, and we said, we really want to get you this drug. And even though this was still the early days of PARP inhibitors when you first went on the first study, because we'll explain to the attendees, the first study you went on was the randomized trial of a PARP inhibitor versus chemo, and you actually got on the chemo arm. But then when you progressed on the chemo, right, you were able to go on the study of just getting the PARP inhibitor, and you knew you'd get it. And so there's actually two kind of shots at trying to get you on the PARP inhibitor. And so you were an early adopter, right? Back when you went on this, the drugs were not approved. You stayed on this clinical trial program all the way from the early days until now, the drug approval, right? And you're still on a PARP inhibitor. You're still on rucaparib post-approval. How did you feel, I guess, when you saw that the drug got approved, and knowing your role in that, again, as a pioneer and as someone who decided to go ahead and kind of take the chance? It must have felt great to see the drug get approved and know that it had worked so well.
Well, it did, exactly, because Rubraca, as it's commonly called, is the first genetic approach to treating prostate cancer. And I, through Dr. Bryce's recommendation, was contacted by the drug manufacturing company up outside of Denver, Colorado, the Clovis Pharmaceutical Company, and they asked if they could use my history. Would I be willing to tell what's been going on? And they got Dr. Bryce and I involved in a similar type of production where we spoke to oncologists throughout the United States and people that were going to be representing rucaparib. So it was, I guess I sort of became the poster child for the Clovis Pharmaceutical Company as it relates to this drug. And I met the owner of the company. Everybody had a sense of muted excitement about the potential for FDA approving this drug. And it just transpired here, probably a month and a half ago, almost 2 months ago now, that the FDA did approve it, and now it's out there on the market. And I'm very hopeful that people that are in this same condition that many of us are, that your oncologist will look seriously into this as a treatment that's very kind to the patient. It's something with very few side effects. I virtually have no nausea. It's just, my days are wonderful, and it's doing a very effective job.
Yeah, that's fantastic. You really you are a patient ambassador. There's no question, right? And because you had told me early on, as when you were going on studies, that you wanted me to put you in touch with patients who had questions. You wanted to be someone who could be helpful. You know, the spirit of paying it forward, I think, lives very strong in you, right?
Yeah, absolutely. It's been important to me through this entire journey that it's not just about me. And I've had a very good life. I couldn't have had a better life being able to live in Sitka, Alaska, where I did. And I guess I've also lived a life where my cup is always half full. And I try to make sure people that are fearful, that are unsure about which direction to go, talk to me. I don't have the answers to everything that's going on with other people personally, but I can tell you about me, and I can tell you what's worked with me. And I also give 99.9% of my success in this entire journey to the direction of Dr. Bryce. He is, as he said, he started out being my doctor, but I would say today he's absolutely my best friend.
Yeah, we're buddies for sure. I don't know if we're allowed to say that we like to sit and have a beer together when we were coming back from San Diego, but
yeah. Well, that was a rare moment. We seldom unmask anymore out here, but that's an important thing to do as well. You know, when you have a depressed immune system, you have to be very careful.
Yeah, that's right. That's right. So, what do you think patients have to think through? Because this whole thought process, as you know, the first time we talked about a clinical trial, you understand risks and benefits and trying to weigh it. I think at some level it's a little bit scary to say to try something where we haven't answered the questions yet, right? We're not quite sure.
Absolutely.
But we feel we're on the right track, right? We have some enthusiasm. How do you think through that conversation? How did you go through it the first time?
Well, I think that's where two things come into play. One is, again, the support that I had from my registered nurse daughter, who believes that you should always investigate your medical treatments, and you need to stay on top of your health, and you don't sit at home and worry about, am I doing something right or wrong? You go and spend your time with your oncologist and get that good information. And then secondarily is spending the time to do the research yourself. As a patient, you can never know as much as your oncologist, but there's enough information out there about if you are going to be involved in a trial or a study or a particular drug. There's enough information out there on the web to find out most of what I think a person needs to be able to say, okay, I'm going to try this, and not have a lot of fear about what road you might be going down. And so far, that's worked for me in every case. And as I said, I guess I'm probably my fourth human trial now through the Mayo, and each one has been a progressive step. The trial worked great for me for a while until the cancer figured out the immunity to the drug or whatever happened. And then I would immediately turn to Dr. Bryce and say, Dr. Bryce, what's next? What's out there for me? So to be on the cutting edge and trying the new things has really been a blessing for me.
That's wonderful. Don, we appreciate your time. I know we're coming up to the last couple of minutes of this time slot. So I do want to, I'll let you get in the last word. Anything you'd like to say to the patients. The last thing I'd like to say to the attendees is, you know, when we're talking about these PARP inhibitors now, and as John's saying, you know, newly approved, this is available to you. You know, it's about 20 to 25% of all men with advanced prostate cancer will have the genetic signature that suggests that a PARP inhibitor is a good treatment option. And what this involves then is your physician has to order the testing. He should be testing the DNA of the tumor. He or she should be testing the DNA of the tumor, which can be done through a blood test or through a biopsy of the cancer. And at the same time, we also check the genetics that you inherited, right, from your parents, and the genetics that you would then pass on to your children. And with those tests, usually, you know, 2 tests, maybe 3, we'll find that, like I say, 20 to 25% of patients who are eligible. And at this point, because there are now drugs available, you know, like rucaparib, this is very much a standard of care test, and we recommend it for every man with metastatic disease who needs to make a decision about treatment. So please do talk to your physician about that. And I'll stop there. I'll give you, John, the last word. Anything you'd like to say to our participants?
Well, I would just tell the patients out there to be courageous. You can't fear your future. You need to live within the day and make every day a positive, good day. Put your trust in your oncologist. Listen to what your options are. Do the background, as I've already mentioned, and you'll have a good outcome, I'm certain, just like I feel I am having. And I'm hopeful. Not every treatment's going to work for every patient out there, but I'm really excited about where the direction is going right now with the genetic studies. And just be open to what's presented to you. You really can't go wrong.
Very good. Thank you, my friend. I'll look forward to seeing you.
Thank you very much.
All right, and now we're going to take a 10-minute break. I don't know if the moderators are coming on, but a 10-minute break, and we'll be back for the next section with Dr. Koo at 12:55.
Hi, and welcome back. To kick off this session on the future of prostate cancer, we have Dr. Philip Koo, Chief of Diagnostic Imaging and Oncology, Physician Executive at Banner MD Anderson Cancer Center, who will discuss theranostics.
Thank you very much, Christy. Happy to be here. Thank you to Dr. Bryce for the invitation, and thank you to Cure for hosting this wonderful event. We can go to the next slide. You know, the idea of an educated patient, I think, is so critical. And, you know, an educated patient, knowledge is power, and having patients in control and understanding the different types of therapies out there and diagnostics, I think really helps make informed decisions with the physicians that are taking care of the patient. And I think this is a great way for all of us to learn, and that goes for us as well. As providers, we want to learn about some of the viewpoints and stresses that patients are seeing, so we could actually be better at what we do as well. Again, when it comes to radiation, there's a lot of misinformation out there, and hopefully through today's talk, we'll learn a little bit about this exciting field called theranostics. Next slide. So theranostics, it's kind of this play on words where you combine therapy with diagnostics and you call it theranostics. Next slide. And what you see here is it really merges these two types of parts of medicine that we often think of separately, but it actually allows the technology to do both at the same time. And through this process, it really creates a major piece of what precision medicine looks like, personalized medicine looks like. Next slide. So just to sort of set the stage, we're referring to this field as theranostics. Oftentimes, if you read various, articles or whatnot, you'll see this referred to with many different terms. One term that is out there is this idea of radioligand therapies. Another is called targeted radionuclide therapies. Another is targeted therapeutic radiopharmaceuticals. So there's a lot of different names out there that are floating around. And, eventually we'd like to sort of create a more standard lexicon for this field, because I think it creates some confusion out there. And that's something that we're working on at the society level to sort of help standardize this. But just recognize it all sort of means the same thing. Next slide. So when we think about radiation therapy, typically what we think about is this idea of external beam radiation. This is where the radiation oncologist, you see a radiation oncologist, they do the treatment planning, and then they send radiation targeted to a specific part of your body. And that is one very, very important part of radiation therapy. Theranostics is a completely separate type of radiation therapy that uses radiopharmaceuticals. So it's different because it's not as targeted. It's not like you're sending a beam to target a specific area, location in the body. It's more systemic. So next slide. So how it works is you identify a target on the cell, and then you create these small molecules that can target that specific protein. And then at the end, you can put different radioactive materials to serve different functions. So next slide, I'm going to use an analogy to help explain this. So this idea of a heat-sinking missile is sort of what I'm going to use. So a missile, typically it's a vessel to deliver something, and typically it's an explosive device. But in this case, you can advance forward. If you put a radioactive isotope that serves as a light bulb, what it'll do is it will help us identify the sites of disease in your body. But what we could do is we could switch the radioactive material, next slide, to something that actually emits radiation, targeted radiation, beta particles, or alpha particles. And what that'll do is, instead of it lighting things up so you can see it, it will actually disperse radiation so we can destroy or kill those cells. So the process is similar. It's just a matter of what we put at the end of that missile that creates the functionality, whether we're going to use it for diagnosis or if we're going to use it to try to treat disease. So hopefully that makes sense. Next slide. And then the beauty and sort of the challenge with radiopharmaceutical therapies is, unlike external beam radiation, where you're, again, sending lasers or beams to target something specific, with radiopharmaceutical therapies, you're actually injecting it typically intravenously. So through your venous system, and then it circulates throughout your body. So you can imagine, once we inject these materials into your system, we don't really have much control as to where it's going to go. And that creates some of the challenges with radiopharmaceutical therapies. And that's why, to me, even though we call it radiation therapy, it's a completely different field because the physiology and the science is very, very different. Next slide. And when it comes to prostate cancer, what we've discovered is that in prostate cancer cells, there's this protein called prostate-specific membrane antigen that is highly expressed in prostate cancer cells. So in patients with prostate cancer, wherever there might be a prostate cancer cell, this protein actually is much more present and prevalent and provides for a very nice target in order to get access to that prostate cancer cell. Next slide. And this idea of personalized medicine, where we're combining diagnostic technologies with therapeutic technologies, sort of works like this. You might have a group of patients, and within that group of patients, maybe only a handful of them actually express that specific protein. What the imaging test helps us do is it helps us tease out, find those specific patients that actually are expressing that protein and put them in one group. And then you have those patients who aren't expressing it and you can put them in another group. So this benefits actually both patient populations, because for those that actually express that protein, we could give them a drug that is specific for that protein, and that drug should work better in those patients. And on the flip side, if you're not expressing that, we don't give you that drug, so you don't have to suffer the unintended consequences, including the financial cost of a therapy that most likely will not work. Next slide. And this is sort of an example of how prostate-specific membrane antigen might not be expressed in every single patient. And this is an example of where someone's prostate cancer cells expressed prostate cancer cells that were glucose avid, where they were using sugar, but they were not expressing the PSMA protein. Next slide. This slide comes from Dr. Michael Hoffman from Australia, the Peter MacCallum Cancer Center, and he presented this at the National Oncology meeting this past June at ASCO. And this is just a nice example how he used a variety of imaging tools to figure out what patients would be best to undergo this therapy with PSMA targeted theranostics. Next slide. This is a publication from a few years ago that talks about the impact of PSMA targeted therapies in these patients. And the beauty of this is that when you gave someone this PSMA, lutetium-177 PSMA, you could actually image them after the therapy as well, helping to confirm that the radiopharmaceutical went to the places that it should have. And you see in this patient that a lot of the disease sites actually got better over time. And this was also corroborated by the fact that the patient's PSA level went down as well. So this was extremely promising and created a lot of excitement in the field. Next slide. And in that study, let's advance to the next slide. Here is sort of the PSA levels in those patients. And you could see that some patients, their PSA levels decreased, but actually in a significant number of patients, their PSA levels did not decrease, which was sort of concerning as well. Next slide. And there have been multiple studies, particularly in Europe and Australia and maybe India and South America, that have done a lot of these single site trials that have demonstrated the improvement, at least in PSA and other markers, that this therapy works. Next slide. And this is just a different type of radioisotope that is used that showed, again, greater response in these patients who had very, very advanced metastatic disease. Next slide. This, to me, is an exciting slide because it shows how during the course of therapy, if you use imaging, you might actually be able to change their management into something that is more effective so the patient can get better response. This isn't available yet, but I think you could see how this can create a lot of excitement and give us a lot of direction with regards to where we need to look at next. Next slide. So for those of you who've been following this field closely, you'll see that there's been extreme levels of hype regarding this new technology. And then there are people who actually don't feel like this is really going to make a big difference. And I think the reality is somewhere in the middle, and that's where we really need to figure out where that middle ground is. Next slide. And in order to find where that middle ground is where we need clinical trials. And the US, for better or worse, is very, very good at clinical trials. And before the US FDA gives their approval for a drug like this, they want to see randomized prospective data. They want to see very controlled tests that prove how, why, the safety of all these drugs before they're going to allow patients to be treated with this. This study, again, comes from Michael Hoffman, and this was a comparison between the lutetium PSMA theranostic therapy versus cabazitaxel, which is a chemotherapy given to treat patients with prostate cancer. And you could see, based on the various criteria, it's a very specific trial. It's controlled. They try, the investigators try to make sure that we can come to a very good conclusion based on the results, whether it's good or bad, because that's what we need. We need to seek the truth. And these trials, as we've learned about today, are extremely important. Next slide. And in that trial, what they saw was that patients who received that PSMA-targeted therapy or that theranostic pathway had a better response in their PSA level compared to those patients who received cabazitaxel. So again, this is more evidence, but in a very controlled fashion, that PSMA-targeted therapies have real value. Next slide. This study is what we are all waiting for in the United States. This is the VISION trial, which I know some of us are familiar with. This is what allowed many patients in the US to actually get this therapy. At this point, all the patients have been recruited to this study. We're just waiting for the data, the results, to be shown before it can be applied and receive FDA approval. Next slide. So this company, it's called Advanced Accelerator Applications. They're now a part of Novartis, which is a big global pharmaceutical company. And this study is a international prospective trial, multiple sites throughout the world. Used it in patients who had metastatic castration-resistant disease and received prior therapies in the past. Total of roughly 750 patients were planned to be enrolled, and 2-to-1 received this drug versus just standard of care. And originally we were hoping to see the data this fall, but I think it'll be not until 2021 until we see the data from this trial that should hopefully lead to its approval in the United States. Next slide. So this leads me to a discussion about overall cancer care. And when we think about cancer care, I think we all acknowledge the fact that cancer care is extremely, extremely complicated. It requires expertise from so many different specialties. And traditionally, when we think about cancer care, we think about medical oncology, surgical oncology, and radiation oncology. And there is no question these specialties are at the core, the pillars of cancer care. But I think this is subtly changing. This is expanding. Next slide. And what we're realizing is, in order for patients to get the best care possible, you really need an orchestra. It can't just be a trio of providers. It's more than just physicians and APPs. It's nutritionists, it's supportive oncology, it's pathology, it's integrative oncology. And within that, radiation oncology and now nuclear oncology is going to play a bigger role in patients with prostate cancer, given the future rise of theranostics. Next slide. And when it comes to this therapy, the specialists that are going to be the ones administering this are what we call authorized users. And it's usually going to be a nuclear medicine physician a nuclear radiologist or a radiation oncologist. And that model is going to differ based on where you go. But I think there's certain comfort knowing that a place like Mayo, a place like Banner MD Anderson is able to provide these services. And again, it's the integration that I think is very critical. It's the communication that people have with each other that really allows the care coordination to get to a higher level. Next slide. So as a radiologist, my job is changing. This technology is disruptive. Typically people think of a radiologist as someone who sits behind a screen all day, just reads cases, has very little human interaction. This is changing because these types of therapies that are combining the diagnostic technology with the therapeutic piece is really changing how we need to approach patient care. And it's a good thing. It's forcing us to get out there and be more involved. And this is something hopefully we could embrace and expand in the future. Next slide. So here's just some of my take-home points. Theranostics and targeted PSMA-targeted therapies, it's a safe and effective new therapeutic option for advanced prostate cancer. It is currently not approved for in the United States, but we're hoping in 2021 we'll see approval. And it is really taking advantage of this idea of precision medicine. So I wrote 2021 maybe for FDA approval, but hopefully we might be able to see it in the clinic in 2022. It's safe, and we've seen that in multiple trials, because the last thing we want is a therapy that is going to be harmful, where the harms outweigh the benefits. And I think what we've seen is that it actually the tolerability of these drugs is actually very, very good. And nuclear medicine and radiology, I think it's an important part of the multidisciplinary care team, and hopefully all the patients out here will get to know who those members of that specialty are that are taking care of them. So thank you very much for your time.
Thank you so much, Dr. Koo. Next, we have Dr. Alan Bryce, Medical Director of the Genomic Oncology Clinic at Mayo Clinic, who will discuss the future of prostate cancer.
All right, well, thank you for having me again. Hopefully people are okay listening to me one more session here. So, as we already heard about from Mr. Litton earlier, there's a lot going on in prostate cancer in terms of clinical trials. And what I want to do is give you a bit of an overview of, where have we been, where are we going, and what can you expect out of prostate cancer. Now, when we talk about the future of prostate cancer care and what's on the horizon, I mean, this is a massive topic, right? With incredible amount of activity, and that's good news. It's frankly wonderful how quickly things are moving forward. So I can't cover the whole field here. I'm going to try to give you, say, a survey, perhaps. Next slide, please. So a brief history. Okay, so the idea that hormones could drive cancers and that modifying sex hormones through surgical methods could somehow change outcomes for cancer patients was actually first demonstrated in the late 1800s when a breast cancer patient had her ovaries removed. And as prostate cancer physicians, we long have this feeling that we were slow to start. It only took another 60 years for someone to say, let's try this in the men as well. And so Huggins and Hodges did the first demonstration of surgical castration to treat prostate cancer back in 1941. And then, it only took, 32 short years for the first study of hormone therapy other than castration. A little while later, we got into chemotherapy. And then you can see that this kind of timeline here from 1980 to 2010, we had a handful of drugs approved once every couple of years. You see 10 drugs approved. Okay, and that was what I call the era of slow progress. Next slide, please. And then we got into what I would say was the era of acceleration. And, this is no accident, right? Here now I'm talking about only 10 years, and you see just as many approvals as we saw in the previous 80 or 70, okay? And the pace of change in prostate cancer now is entirely different from what we once saw. And this is not an accident, right? All of this advancement, these new drugs, what you heard about from Dr. Koo, these were happening because of research, right? And because of organizations, quite frankly, like the Prostate Cancer Foundation, but also the universities, the academic centers, the governments like the NCI, the National Cancer Institutes overseas as well, have put so much effort into prostate cancer that our knowledge of this disease, of the underpinnings of this disease, is entirely different from what it once was. And we've been able to use that knowledge to then come up with therapies that aren't accidental, right? I mean, these discoveries didn't happen on accident. They happened because people were really looking at the basic research that was discovered in the lab and developing hypotheses for how we could attack the cancer. So here's a list of what happened in the subsequent 10 years. And then next slide. You know, now I want to talk about what's coming. And we continue to accelerate. Those of you perhaps like me are a bit more pop culture savvy in terms of sci-fi. That's actually hyperspace from Star Wars, not warp speed from Star Trek, but the concept is the same. We are now moving at tremendous pace in terms of advances in prostate cancer. And you know, let's be clear. I mean, you know, my central goal as a research oncologist, as a prostate cancer researcher, I mean, my real goal is to put myself out of business, right? We want to cure this disease so that we never have to have these conversations again. And so this is a screenshot from clinicaltrials.gov. This is the National Institutes of Health website where trials get registered and listed. I took this screenshot earlier this week. 1,653 active trials in prostate cancer. Okay, I mean, I took out those that are suspended, that are completed, whatnot. This is just active studies in prostate cancer today. Next slide, please. And because I'm an oncologist, I think in terms of advanced disease, right? You know, we heard earlier from Dr. Chioli about radiation and Dr. Tyson about surgery. So, you know, I'm not going to touch on those fields. I'm really going to look at the more advanced disease space and, you know, really try to treat this with a broad brush, because I can't talk to you about 1,600 studies, right? But big categories, big picture. Immunotherapy research is absolutely moving forward very rapidly. And we're going to talk some more about that. I'll give you some specific examples. But you've probably heard about, for example, CAR T cell therapy. These are chimeric antigen receptors. Okay, and you'll see some slides later where I'll try to explain to you perhaps what that is. Bispecific T cell engagers, checkpoint inhibitors. You know, you've heard about immunotherapy. You've heard about how it's transformed the care of other cancers. Now, truly, we haven't quite cracked the code yet in prostate cancer, but we're still trying, and I do believe we'll get there. So I'm going to talk to you some about how that looks. PSMA targeting. You heard from Dr. Koo about this, so I'm not going to go into it too much more, but only to really emphasize and you know, support his point that this is transforming the field. There's very exciting things happening in this space, and the radiotheranostics, both the diagnostics and the treatment, are absolutely exciting advances in prostate cancer. And we think, you know, probably the next near thing on the horizon for current patients. Hormone therapy. I know most patients know about this because I get the questions a lot. What about giving testosterone, right? And there's research into something we call bipolar androgen therapy. So we'll talk a little bit about that. You heard, of course, about PARP inhibitors. We touched on that earlier. There are increasing numbers of PARP inhibitors. There are approved agents now. And so we'll talk about what's next with this class of drugs. Other genetically directed therapies, other targets beyond the DNA repair genes that you heard about with PARP inhibitors. And then what about, you know, metabolic or environmental approaches to trying to affect prostate cancer? The next slide, please. All right, so CAR T cells, and I'm going to walk through some of the examples we're talking about. So what is CAR T cell therapy? It is an example of what we call adoptive cellular transfer. So this is any one of a variety of therapies where we're taking cells from the patient, whether it's the patient's own cells or from another patient. Okay, we're taking cells from a patient, we're taking them to the lab where they're getting engineered in one way or another, and then infused back to the patient. CAR T cells is, you know, the classic example of that is bone marrow transplant. Okay, but the CAR T cells are a more specific example where what's happening is the T cells are a key part of the immune response to cancer. The T cells are the cells that would attack cancer. But in order to do that, they have to first recognize the cancer for what it is, right? A harmful foreign cell. Now, there's a variety of reasons why T cells or innate T cells fall short of that and can't recognize the cancer and can't mount a response. So what researchers at the University of Pennsylvania and elsewhere figured out is that they could take your cells, your T cells, out of your body and then use viruses to introduce a new receptor onto the surface of the T cell. And these receptors are highly engineered. They have specific components, but the most important component is a component on the outside of the T cell, which is specific for prostate cancer or for the cancer of interest, okay? And then these signaling domains inside, which then turn the T cell on. So this is really forced recognition of the cancer, okay? And, 5 years ago, this was still sci-fi. This was an exciting idea. We all loved the idea, but it was hard to believe that it was going to be possible. And yet, in 2017, oncology care was transformed because 2 CAR T products were shown to work in very tough cancers. So in pediatric leukemias and lymphomas, where, we're talking about patients who were within just a few months of death, this CAR T therapy has apparently cured some of these patients. They're still alive today. And so in prostate cancer, there's now 8 prostate CAR T trials currently active or pending on clinicaltrials.gov. The key here is that the antigen that is being attacked is prostate cancer specific. So PSMA you heard about, that's one example of a target that's being used for CAR T therapy in prostate cancer. And these trials are now up and accruing, and hopefully, hopefully we're going to start to see over the next few years some results come out of this. The optimism is very high. Next slide, please. Another way to try to accomplish the same thing involves something called a bispecific antibody. So what this is you see in the top picture here, okay, the typical way a T cell engages with an antigen presenting cell, another part of the immune system. It activates the T cell, and then the T cell goes and hunts out the cancer cell. Okay, a bispecific antibody is an antibody that's been specifically engineered so that it has 2 arms, one arm that recognizes and attaches to the cancer cell. So here again, something like PSMA. Okay, and then a second arm that attaches to the T cell. So really, what this is forcing the T cell to come into contact with the cancer cell. Right? It wasn't able to do it on its own, but this antibody forces that engagement. And we just saw last week some of the first results from a bispecific for prostate cancer, this drug called AMG 160, with a very high PSA response rate of 69%. This is tremendously exciting. And so the phase 3 study is now pending, will be open soon. This is a very large study. You're going to see at sites across the country, including Mayo Clinic, presumably MD Anderson as well. And again, this is real immunotherapy, but the advantage that this has over, say, CAR T therapy is that you don't need to do a stem cell collection. You don't need to do any engineering of the product. When we engineer a product, it can take a few weeks. This is an off-the-shelf product that you go into the physician and you get by IV. So we've already seen these types of technologies work in other cancers like myeloma. Now it's coming to prostate cancer. Next slide, please. Checkpoint inhibitors. This is the traditional immunotherapy you've heard about for other cancers, for lung cancer, melanoma, bladder cancer, others. This is a kind of therapy that President Carter got for his melanoma. Checkpoint inhibitors, haven't really worked yet in prostate cancer quite the way we'd like. The response rate is generally poor. Maybe in highly selected populations, you get closer to a 10%, but generally very low and not anything quite good enough yet for an approved drug. There are some non-prostate cancer specific genetic markers like high tumor mutational burden or high MSI that would actually qualify a patient, a prostate cancer patient, for getting a checkpoint inhibitor. But this is, 2 to 3% of prostate cancer patients, so relatively uncommon. But despite that, we are still working at cracking this code. And as I put there, there's over 100 clinical trials ongoing with checkpoint inhibitors in prostate cancer, combinations with other drugs, trying to find a way to make these drugs work for prostate cancer. And our optimism remains high. This is the fact that we haven't made it work yet. It doesn't at all discourage us from thinking that we're going to find a way to make it work. We just need to tweak the recipe some, or so we think. Next slide, please. So PSMA targeting, and again, I'm not going to talk a lot about this because Dr. Koo already did, but radiopharmaceuticals are coming along. And as much as we talk about, lutetium-177, that's not the end of the story at all. There's next generation PSMA targeting radiopharmaceuticals using alpha emitters such as actinium-225 or thorium-227, other beta emitters including copper-67 and terbium. So this will remain an active space, and you are going to see clinical trials. You're going to see combinations using the existing drugs, assuming that lutetium gets approved. You're really going to see a significant ongoing advancement. We're not slowing down here. We're accelerating still. And again, bispecific antibodies like I talked about, and imaging like Dr. Koo talked about. Next slide, please. Bipolar androgen therapy. Again, this is something that patients really like, the idea of can we give a patient testosterone rather than taking it away. I do put this here because there are some results. The Johns Hopkins group is really leading this effort, and they've shown some positive results. But I also put it here because there is oftentimes a misunderstanding from the patient from what we really mean. So the focus here is bipolar. That means up and down, okay? This is not a therapy where we're actually taking a prostate cancer patient and giving them, bodybuilder type steroids, okay? What we're doing is we're suppressing the testosterone in the normal fashion, right? Whether it's Lupron or surgery or whatnot. And then the patient gets short pulses of high dose testosterone. Okay, and the idea here is to cause rapid cycling of the testosterone levels up and down, and to confuse the cancer cell, and perhaps, at the very least, delay the time until the cancer cell becomes resistant to hormone suppression. So the Johns Hopkins data is promising, but it's ongoing, it's still early, and it's still fairly small phase. So what you're going to see out of this is ongoing clinical trials in the future. And again, this is an example where we have to crack the code. There may well be a good way. There's probably a number of bad ways to do it. And rest assured, the prostate cancer research community is definitely looking at this, and we're very interested in trying to figure out how to make it work. But it's still research. I do not recommend that patients have this done outside of clinical trials. Okay. PARP inhibitors. We've already heard about that from Mr. Litton. 2 PARP inhibitors are now approved for use in metastatic castration-resistant prostate cancer. 2 more are still in testing, and over 30 different trials are currently listed on clinicaltrials.gov using PARP inhibitors. And so when we first get a drug approved in any cancer, the natural history of drug development is you get your first indication typically late in the disease course. And there's ethical and practical reasons why we test drugs late first, but immediately and already we start trying to move those drugs forward. We're definitely trying PARP inhibitors in much earlier lines of therapy, even preoperatively. Combinations with the other drugs, oftentimes there's synergy between using different drugs for the same disease. So there's still a very robust PARP inhibitor research pipeline, and I would encourage patients to consider getting involved in that. Next slide, please. Genetics. So you heard us say earlier, and you can't make this point enough, every man with advanced prostate cancer needs to have his family inherited genes checked. This is an official recommendation. Here at Mayo Clinic, we did a study of over 3,000 cancer patients. About 400 or 500 of them were prostate. This paper was actually just accepted into JAMA Oncology, so you'll see it in print soon. And in our testing, if you ignore family history and just test the cancer patient, right, 15% or so are going to have some kind of high-risk gene that they've inherited. And that means also then that there's a 50-50 chance, right, that they'll have passed it on to each of their children, or each child has a 50-50 chance. Each sibling of the patient has a 50-50 chance. And this matters now not just because of counseling for the family, but also because these genes like BRCA2 and BRCA1 are what would qualify the patient to benefit to receive a PARP inhibitor, right? So this kind of testing is both to help the patient himself in terms of his treatment selection, but also to help the family. You know, the best way to cure cancer today is still what it's always been, which is catch it early, treat it early, and don't wait until it gets to an advanced state, right? So early detection is the most important piece of cancer cure, even in 2020. And then testing of tumor mutations. You've heard this, how tumor mutations can affect the eligibility for treatment selection, both for immunotherapy and for PARP inhibitors. So this is standard today. Advanced prostate cancer patients should have their tumors tested for genetics. And I assure you, I guarantee that in the coming years, you're going to see that there's going to be more and more drugs that are specific to mutations. And what's going to happen is instead of saying to a patient, you have, prostate cancer and everyone fits in one bucket, we're going to divide out prostate cancer into a lot of different types depending on the genetics with unique treatment paths and recommendations. So as you see there listed on the right, there's genes that affect therapy, and we've talked about it. There's research going on into other genes, MAP kinase activating mutations, CDK4/6, a lot of other genes of interest, too many to list here. But this is going to be a big part of the future of prostate cancer management. Next slide, please. Metabolics, absolutely. We've heard these questions earlier in the day, and it's always a big part of the conversation. What about diet? What about exercise? What can we do on a metabolic level to affect cancer? For a long time, metformin seemed interesting, and we had some negative studies, but now in the last week, we see some positive data. And it's causing there's a lot of interest here. And this is something that the prostate cancer community is trying to figure out. Is there a way to integrate this really safe, common drug that's used for diabetes into prostate cancer care? Exercise remains key. There's no question. We take away your testosterone, right? There's some muscle loss, there's loss of bone density, but exercise can counteract that. What I would say is what's ahead is there's a lot of emphasis now on prehabilitation. And this is what we try to do in our practice here at Mayo. We start talking about the diet and the exercise, hopefully from day one, but hopefully even before, right? When you start to get into a certain age group, even when your surgeon's talking about surgery, we want to start that exercise program as early as possible before we start giving the drugs that are going to start causing some of the side effects that reduce fitness. Cardiovascular risk management. You hear this a lot in prostate cancer. Still some debate about, to what extent is the prostate cancer drug causing the cardiovascular risk versus, aging and lack of exercise. But without question, men who get prostate cancer are in the same risk group as men who get cardiovascular disease, right? This is older men. So at Mayo Clinic, we have a cardio-oncology clinic. These are cardiologists who specifically treat cancer patients. And a very high proportion of all my patients see both the cardio-oncologist and myself. Active management of cardiovascular risk factors should be standard of care in prostate cancer. The microbiome. This is tremendously exciting research that touches almost every cancer and frankly, health in general. But we're starting to understand more and more how the actual mix of bacteria on our bodies, in our gut especially, but even, say in our nose, on our skin, wherever else, actually affect our health. And that there are potential ways then to manipulate that bacterial population in ways to benefit the patient, possibly to make treatment more effective. There's even research, and the Prostate Cancer Foundation funds some of this, looking at how can you change the microbiome of the gut to make immunotherapy more effective. It's already been shown in rats. It's a tremendous finding that you can take a rat who doesn't respond to immunotherapy and you can transplant, right, the stool from a rat who did respond to immunotherapy, give it to the one who didn't, and suddenly the rat who used to be resistant suddenly starts responding. The tumors are shrinking. So we're trying to do something like that in humans, and that research is ongoing. And then pharmacogenomics, we all know these people who say, look, I respond poorly to every drug, or those drugs never work for me. Every patient's different in terms of how drugs respond. Some of that difference from person to person has to do with how your body metabolizes drugs. It's the enzymes in your body. And the field of pharmacogenomics is still very early in cancer care. In psychiatry, they can do a test right off the bat and say, okay, here's the antidepressants that are going to work for you, and here's the ones that won't. And obviously, knowing that up front can accelerate our drug selection for patients and getting the patient to the right drug right from the get-go, rather than having to experiment with a variety of drugs before finding the one that works. Next slide, please. So what's ahead? In principle, what we always say is the only good cancer cell is a dead cancer cell, right? We want to cure this disease. And the fact of the matter is, in the last 10 years in cancer care, we have cured a whole list of cancers previously thought to be incurable. And when I was a fellow in the melanoma clinic, it was almost a hospice clinic. The vast majority of patients passed away within 12 months. And yet in 2010, Yervoy finally came, or 2011, it was finally approved. And this was the first real immunotherapy drug to ever work in a randomized clinical trial. And today, over 30% of metastatic melanoma patients can expect to be cured. It was 0% just 10 years ago. We are waiting for that moment in prostate cancer. And I absolutely believe that before I retire, that we will see cures in prostate cancer. If we continue with the same energy, the same commitment that brought us to this era of warp speed, with the commitment of support from patients, from foundations, from the NIH, and from the research community, things are moving so quickly now. I absolutely expect we're going to cure this disease. So we need to continue our research on multiple fronts. We need shots on goal. I always emphasize this. I do a certain number of studies. I do certain lines of research, but we need diversity. We need a lot of smart people working in a lot of different directions. We need lots of shots on goal, because frankly, you don't know which one's going to score and win the game for you, right? My goal, like I said at the top, my goal is to put myself out of business, right? I ask for your help in that, right? I'm an oncologist right now, and I hope before I'm done that people won't need prostate cancer oncologists anymore. So next slide, please. So thank you very much. These are my 4 boys who would be happy if I, retired young, although with the cost of college nowadays, I'm sure that's not going to happen exactly. That was them last Christmas. My oldest is Joseph. My second boy there is a wise man. My third boy is apparently a Power Ranger protecting baby Jesus. That must be one of the new Gospels. And then that's my baby James there, now 2 years old. So thank you very much.
Thank you so much, Dr. Bryce. Now for this panel, joining Drs. Koo and Bryce will be Meryl Gray from the Prostate Cancer Alliance. So to start, we'd like to open the questions up to the audience again. We had a couple come in while both presentations were going on. So one question that came through, will PSMA play a role in prostate cancer? And when will that be, maybe potentially available in the United States?
I think the sign is wrong, the panel discussion. I'm not Ed.
Oh. Sorry about that.
It's okay.
Do
you guys want me to repeat the question?
So when will PSMA come into place, right? So ultimately, the first registration trial for PSMA-directed radiotherapy, as Dr. Koo mentioned, has been completed. And we're very hopeful that we'll get those results out and the FDA will be able to review it and perhaps give us an approval in 2021. I mean, that's the hope. We never know, because it really depends upon the data, right? And so the full data has to be released. And the way this process works is then the FDA and the research community is going to go over it with a fine-tooth comb, right? So it's not that anybody lacks the sense of urgency. But I think COVID actually has taught the non-medical community a lot about how clinical trials should and shouldn't be conducted, right? And about the dangers of rushing data out too early, right? Science is a process. It's very important that we dot our I's, we cross our T's, and we do it the right way, and we don't take shortcuts, right? A lot of COVID, studies took a lot of shortcuts, and it caused a lot of problems. We're not doing that in prostate cancer, and that's why, like I say, I think it'll be into 21 before we see anything from the vision study, but that's a good thing. That's not a bad thing. So because we want to be careful and get it right.
So one thing I'll add is, when it comes to the diagnostic tool and just for PSMA imaging, what's nice is there are actually 2 NDAs. There are 2 applications that have been submitted to the FDA for approval. So we're hoping maybe by the end of the year, at least one of these gets approved, and maybe early 2021, we'll be able to image patients with PSMA PET CT more widely.
Okay, and so we had another question. Can currently available PET or CT scanners handle PSMA therapy?
So absolutely they can. So the beauty of PET is a imaging tool. It's like a CT scanner or an MRI scanner. PET is the actual imaging device itself. What we inject into patients, we can inject whatever we want to, just as long as it's a positron emitter. And if it's a positron emitter, PE, then it can be imaged by a PET scanner. So the good thing right now is throughout the US, pretty much every patient has access to a PET CT scanner probably within an hour. The tricky thing is the radiopharmaceutical, what we're injecting into the patient, the availability of that material is much more limited. But we're hoping by 2021 that becomes a non-issue. So everyone in the US will be able to get that imaging.
Great. And how does CAR T therapy compare to Provenge immunotherapy?
Yeah, so Provenge is definitely a very different class of immunotherapy. It is still an adoptive therapy, right? I mean, there's an apheresis step. The cells are extracted, they're cultured to try and activate them against prostate cancer and then reinfused. But that's a very early generation technology that really isn't very comparable in the type of immune response it stimulates, or even in the toxicity. I mean, CAR T therapy actually can be very toxic, right? Patients can end up in the ICU and whatnot. But that toxicity is also evidence of how robust the immune response is that gets unleashed. So I would say it's a very different paradigm altogether. Even though some of the steps sound the same, it's really not the same technology.
And
May I add something, Christy? I think with all the lengthy discussions on clinical trials, we should not underestimate the value of advocacy and patient advocacy and informing. And I think informed is one of the key words. Informed discussions, informed decision-making. A summit like this is invaluable to patients, and we at the National Alliance of State Prostate Cancer Coalitions, we have these decision tools. These are 2-sided laminated tools on 7 different subjects, beginning with testing at the very beginning, all the way through advanced prostate cancer, non-metastatic, castrate-resistant, and metastatic castrate-sensitive, the works. And we also put on webinars. And I think to the extent that we can educate patients, and we're also educating physicians as well with these 2-sided laminates, because one side is for physicians, I think we will increase the number of shared decisions that are based on information, and we'll move medicine along. We'll move the trial recruitment along. Trial enrollment will be closed, and I think we'll be able to move a lot of these things into the clinic.
If I might add to that, I think that's a great point. This idea of advocacy, it's priceless, and we've actually seen the impact of advocacy with regards to access for a lot of these drugs for patients. So when it comes to imaging agents, oftentimes Medicare, the government's very quick to pay money for therapies, which is, we should. These therapies are good. They make a difference. They should be provided for our patients. But when it comes to diagnostic technologies, interestingly, there's not a huge appetite to pay or reimburse or approve these types of technologies, which to me is very short-sighted. And I know the advocacy groups can have a huge impact in helping our legislators understand the importance of diagnosis, which then helps us make better decisions about treatment. So thank you all for your help, and we look forward to even more help in the future.
Absolutely.
Definitely.
I agree. I mean, for the patients, if you do go to the lobby of this seminar, you'll find some links through the PCF and others for resources. And you know, you heard that from Mr. Litton earlier as well. I mean, trying to be informed. You know, you are your own best advocate. Your physician, you know, I'm on your side when you're my patient, and it's a partnership. But without question, I mean, you know, there is so much information out there. You know, these organizations that advocate and that provide this education are invaluable for patients.
If you go to the exhibit hall and go to the NASPCC booth, that's us, you'll see a number of resources, whether it's links to our most, the three webinars upcoming. The first one, Michael Morris is going to do a webinar for us on October 1 on PSMA imaging. You'll also see a link to the informed decision-making guide that I mentioned. We have 6 others and 6 different topics that are in press. And you'll also see we took over Prostate-Pedia magazine, which also has not only a quarterly online issue, but a weekly digest with links to everything recent, whether it's abstracts, research, ESMO findings, the works, that goes out every single week to over 12,000 people. So please visit our exhibit hall and see all the ways we can help you, and feel free to reach out to us. We represent 46 states out of 50.
Absolutely. So we had a lot of questions come in about genetics, but before we get into that, there was also a question about the Foundation One liquid CDX test for detection. Can one of you maybe discuss that a little bit further?
Sure, I can address it. So the genetics is a little bit difficult to understand because there's a few options, right? So let me roll the talking about the liquid test kind of into the general discussion. Okay, so the first distinction when we talk about testing genetics is the one I touched on earlier, which is there's the genes you inherit, right? And those are the genes you pass on. And so that's what we call the germline. And then there's the tumor genes, right? So remember, a cancer cell, I mean, by definition, cancer is a genetic disease, and the cancer cell is your normal healthy cell that mutated to become a cancer cell. And we test both of those things for slightly different but overlapping reasons, okay? So if you want to test your inherited genetics, that's either a blood test or like a cheek swab. You know, these are like there's some of these commercial tests out there that'll tell you, you know, what's your ancestry, that type of thing. It's the same test, just looking for different things. The tumor test can be done a couple of different ways. The gold standard is still to test the cancer cells themselves by doing a biopsy, right? So you do a biopsy, we get some cancer cells, we extract the DNA, and we can do very comprehensive testing of the DNA of the tumor. But in prostate cancer, it's a fairly common problem that there's nothing we can biopsy. You know, a lot of men have disease that's mostly in the bones. And the problem with a bone biopsy, number one, it can hurt. But number two, there's actually not a lot of cancer cells, and all those spots you see on that bone scan and those CTs, when you biopsy it, most of what you get is bone, and there's only a few scattered prostate cancer cells. So what ends up happening is by the time you extract the bone and you know, try to extract DNA from the cancer cell, the yield is really, really low. So I don't like doing that at all. And so what we can do in that case is what you mentioned, Christy, which is a blood-based test for cancer DNA.
Mm-hmm.
So every cell in your body is constantly shedding DNA. It's just part of the natural turnover process. This is the same technology that obstetricians can now use to tell a woman 4 weeks into her pregnancy whether she's having a boy or a girl. It's the exact same technology. Those cells are, you know, that DNA is just being shed. So we can now extract blood from the patient and look for DNA in specific genes, look for the DNA and say, is there a mutation there? And if that mutation is not present in the patient's healthy cells, then we know it came from the cancer cell. Mm-hmm. Now, what I say about that is 2 things. One, when we find a signal in the blood, it's accurate. There's plenty of studies that have shown this, that what you find in the blood is what's happening in the cancer cell. But there's 2 problems. There's a long list of types of genetic abnormalities that you just can't detect in the blood for a variety of technical reasons. And number two, the yield depends on how much cancer there is at a given moment. So there's just a limit of detection. You have to have enough DNA floating around. So with a blood test, a positive result is real. Positive is positive. There's something there, but negative is not negative, right? You might have just missed it, right? So gold standard is still the biopsy, but if you can't get a biopsy, then a blood test is a really good way to try to understand what's going on in the cancer cell.
Okay. And there was a suggestion that every patient with advanced prostate cancer needs to have their genetic testing done. But a patient asked, how do you define advanced prostate cancer?
Yeah, so it's actually a technical definition. We have an official definition for very low risk, intermediate, high, very high risk metastatic. Okay, so it's a combination of are there metastases or not? What's the PSA? What's the Gleason score, et cetera? And it plugs right into an algorithm. And so your patients can certainly go to some of these websites and kind of see that. But like I say, PSA, Gleason, and then staging kind of tells you which category a patient falls into. Kind of the short answer is, active surveillance patients really don't need it, right? Metastatic patients absolutely do. And then there's a range in the middle. The high Gleason score patients certainly need it. The patients with high PSA above 20, they'll fall into the higher risk category. They should have it done.
May I just add, I know you're discussing the blood tests and the companion diagnostics. We're working with Foundation Medicine, so I'm really familiar with that. But also there's a whole slew of urine-based tests, which patients really like because it's non-invasive. So everything from exosome, all the exosome tests, there's a new company, MIR. There's a lot going on with urine that I think we'll be hearing a lot more of in the future.
Okay. We were also asked, is there any research being done for the CHEK2 gene mutation?
The CHEK2 does fall into the panel of homologous recombination repair or DNA damage response genes, various names for it. But those genes that fall into the family that might have some activity with the PARP inhibitors, at least they were included. Now, the outcomes really weren't that impressive, right? So we've kind of diverted and we're going in a different direction now. But this is a gene that's involved in that process of DNA repair. It's on everyone's radar. So yes, there is research going on, but no, it's not anything that's close to being solved at this point, in my opinion.
Okay. So we have another PSMA question. Could PSMA scans replace Oxymin scans as being more accurate?
So absolutely. I think people are going to try to hold on to Oxymin, some people, but there's no doubt that the performance of PSMA PET-CT at all PSA values is much better than Acumen. The beauty of PSMA PET-CT is that if you have biochemical recurrence and your PSA level is less than 0.5, the PSMA PET-CT still will have a greater than 50% chance of detecting where that disease is occurring. And then if you could actually detect disease at that low a PSA level, imagine the possibilities with regards to what you could do with treating those mets that you find that early. And that to me is one of the beauties of this imaging tool. Potentially, you can get radiation to these sites of disease when your PSA level is extremely low and maybe even cure your disease. So that to me is what's exciting. Acumen PET-CT has been a great intermediary. It's available today. So if that's all you have today, I think it's a great test. But this is what we're talking about with Dr. Bryce's warp speed, Man, Acumen was a great step forward. Choline was a great step forward from Mayo. Then Acumen came along, and already in a few years, we're going to have PSMA PET-CT. This is a success story. It's not something it's the natural evolution of research and progress.
Mm-hmm. I know there was mention of the multidisciplinary approach, and we actually had a patient ask, because there's so many treatment options and there's so many more, in the pike, that Dr. Bryce talked about. So how can the multidisciplinary approach play a role in helping patients to understand and then determine their treatment options that's best for them?
So the multidisciplinary, like, it's amazing. When I sit in these types of forums, I learn so much, even though I specialize in prostate and GU malignancies as a radiologist. Only 10, 15% of my practice is actually in that disease site. But then when I hear someone like Dr. Bryce speak, it's amazing how much I learn every single time I hear him or someone else like of his caliber speak. So to me, you then bring these experts into one room to re-review your case, provide expert opinion, and then you could see that, the dynamic, that occurs in that room when people are having active discussions and they know the latest data, it actually leads to better decision making. And I think that's been shown in various studies. Also, it helps to educate all of us. I think none of us should be too proud to recognize that we don't know everything. So even that, it helps keep all of us accountable. And in the end, I think it helps. And I think we all need to recognize that. The idea of getting a second opinion at a place like Mayo, at a place like MD Anderson, that's a good thing. We want to promote that. It's not that you have to always get your care at these places, but it's important that once you start down the path, you can't change that path. So let's make sure you're going down the right path from the get-go.
I totally agree. The more information the patient has, the better decisions they can make because they're informed, and they're going to feel more comfortable with the decisions, have less decision regret, and knowledge is power from whosever viewpoint you're looking at it from. So we totally agree with that.
Definitely. So we have another genetic question. It's kind of twofold. So for men that have prostate cancer, and let's say they come back with a genetic predisposition, should daughters of these fathers be getting tested? And then moreover, for men, women, anybody in that family that should be getting tested, what kind of test should they be asking for?
So extremely important question, because this is something where even still the medical community, I give this exact talk a lot, frankly, and that's not what we did today, but the most common familial gene that causes prostate cancer is BRCA2. Okay, now most people know BRCA because it has the breast and ovarian cancer gene, and you hear about this from Hollywood and whatnot. Angelina Jolie and Christina Applegate and others who had bilateral mastectomies and had their ovaries out because they carry the gene and they don't want to get breast or ovarian cancer. But what still gets forgotten is that prostate cancer and pancreas cancer are also BRCA associated, right? So when a woman has breast cancer, her doctor's talking to her, says, is there a family history? They should be talking about prostate, pancreas, breast, and ovary, not just breast and ovary. And the same thing for the prostate cancer patient. We should be talking to them about breast, ovary, pancreas, as well as prostate. And so there is no gender limitation at all, right? Anytime a patient, man or woman, has a familial cancer risk gene, it affects everybody in their family, whether male or female. It's a 50% chance that any first-degree relative carries the same gene. And then what we do is we absolutely recommend that the relative then get tested. They get tested for the specific gene, but we help them with that by setting them up with a genetic counselor. And there's a whole counseling process, to kind of let them know, this is the gene we found in your family member. This is what it might mean. These are the cancers that it can cause. And if you have it, this is what we recommend for screening for early detection. That's really the key, right? Is to say, if you're at risk for cancer A, B, or C, what is the screening test you should have, and at what age should that begin?
Definitely. And so with that, also, why is it important for, I know a lot of these patients who just ask these questions, why they should really talk about their family history to make sure that maybe they should or should not be getting tested?
Yeah. So it's important. So a couple of things, I do about 90% prostate cancer. I see these men all week long, and most men don't know their family history, but their wives know. So the wife comes to the appointment and tells me what's going on, right? But the recommendations now for testing, getting familial gene testing, doesn't matter what your family history is. Okay. So this is really important. If a man has advanced prostate cancer, high risk, very high risk, or metastatic, he needs genetic testing. That's the recommendation. And it doesn't matter about the family history. And the reason for this, right, in the old days, it was all based on the family history, and we put together the family tree chart and everything. And that made sense back in the day when the average family had 5 or 6 kids, right? And you had lots of siblings, you had lots of cousins. There were enough people that a gene would show up and you'd see it. But in the modern era, right, with 2 kids per family, maybe less, maybe someone's an only child, maybe people are adopted. What do you do for the adopted patient, right? And the answer is you don't need family history anymore. If you have advanced prostate cancer, you ought to be tested. Doesn't matter what's in the family.
Well, thank you all so much. That's all the time that we have. I really appreciate it. Thank you so much, Dr. Bryce, Merrill, and Dr. Q. So that brings us to the end of our day. But before we adjourn for the day, we want to call the winners of our $200 Visa gift cards. We'll spin.
This is great.
So our first winner is Raymond Lanes. Congrats to Raymond.
Doesn't really want to move around.
Our second winner is Cheryl Alba. Congratulations also to Cheryl. So before we adjourn again, just a reminder, please be sure to fill out the surveys that we'll be sending via email later on to your inbox. So let us know your thoughts about the patient summits. It's with your feedback that we plan to continue to host events just like this. I'd also like to thank our partners and our sponsors one more time for making this event possible. Sun Pharma, Clovis Oncology, the Prostate Cancer Foundation, the National Alliance of State Prostate Cancer Coalition, Fans for the Cure, and Cancer Support Community. We hope that you all enjoyed our virtual summit. Thank you again, Dr. Price, for helping us to plan this today. Thank you for attending, and thank you so much to our faculty for providing such insightful information. Take care, and everybody have a great day.
Thank you so much.
Thank you.